As part of the pre-orthocon workshop, an effort towards engaging our postgraduates and young consultants into this focused area of arthroscopic work. And what we'll try to do we agreed in the scientific committee led by Dr. Haroon is that we'll have focused workshops rather than very generic workshops on bigger themes. So in coming days, you will see some of those themes, but all will depend, of course, on the pandemic situation and the allowability by the university of a group of people. So we will begin without wasting further time. In the name of God, I request Mujib Bhai to please start with Tilawat al-Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين صدق الله العظيم
Jazakallah. Allahumma salli ala Sayyidina Mawlana Muhammadin wa alihi wa barik wa sallim alayhi. As-salatu was-salamu ala khatim nabiyyin. Thank you again for coming, and we will begin before we begin the scientific program, we will begin with introduction. And I will request all of you to introduce yourself as has been our tradition. So just next 5 minutes. We'll be here till 2 p.m. Spending next 5 or 6 hours here. So we will begin with our great friend, Peer Saab from Hyderabad. He needs no introduction, but please introduce.
I'm Dr. Khaled, Professor inside University.
Assalamualaikum everyone. I am Dr. Mohammad Kazim and I am consultant orthopedic surgeon at Yale National Hospital. Assalamualaikum. I'm Khaled Mahmood Shah. I'm also a consultant in Karachi.
Khaled Saab ने बड़ी कैसे नफसी introduction कराया, but let me say a couple of things. He is the pioneer arthroscopic surgeon in Pakistan who established the Pakistan Arthroscopic Forum, who is currently leading the Pakistan Arthroscopic Forum, as well as recently established the Pakistan Society for Sports Surgery. And we will be launching that very soon under his leadership. So a very pioneering person. And today, whatever we are seeing are the fruits of his efforts as a person who is a true leader. So thank you, Khalid Saab, for coming.
Thank you very much.
I'm Professor Mohammad Javed Iqbal from Thessalys Medical University.
I'm Dr. Irfan Rao, Assistant Professor, Radiological Signs, Karachi.
I'm Dr. Rahaj Ali, resident orthopedic surgeon in now University of Science.
Dr. Fahad Mehman, resident orthopedic civil hospital.
Dr. Muhammad Waqasan, civil hospital resident.
I'm Dr. Kamchiraj, I'm an orthopedic fellow at University.
Dr. Mohammad Yunus, resident orthopedics, Al University.
Sharif?
मेरा नाम काशिफ बशीर है और मैं फिजिकल थेरेपिस्ट हूँ और मैं आपको यहाँ पे पोस्ट रिकंस्ट्रक्शन रिहैबिलिटेशन एक्सरसाइजेस के बारे में बताऊँ।
Assalamualaikum everyone, Dr. Shahjamal, resident of University Hospital.
Assalamualaikum, Zaid Shamsi, orthopedic resident at AQ.
Assalamualaikum, I am Dr. Mohammad Ghazi. I am the orthopedic fellow at Shahid Mohammed Group from Institute Civil Hospital, Karachi.
Hi, I'm Abira. I'm registered nurse at ATU.
Assalamualaikum. This is Dr. Syed Lalli. I am a orthopedic surgery veteran at Civil Hospital, Karachi.
Assalamualaikum, Dr. Muhammad Azam Kambo, resident orthopedic surgery, Dow University of Tanzania.
Assalamualaikum. I'm Dr. Rufina Ali, resident orthopedics at ATU.
Assalamualaikum. I'm Dr. Keith, resident orthopedics at Cleavage.
Assalamualaikum, Muzaffar Ali Khan for
Assalamualaikum, I'm Moiz Ali, resident orthopedic surgery at Hospital.
Assalamualaikum, I'm Ahmad Shahid, resident orthopedic surgery at Hospital.
Assalamualaikum. Dr. Syed Umar Rafiq, resident orthopedics at
Assalamualaikum. Sayyid Afzal Ali, orthopedic operating room supervisor, Al University Hospital.
Assalamualaikum, I am Mubashir in Al Hospital.
Assalamualaikum, Dr. Kokar, orthopedic technician.
Assalamualaikum, I am Zafar Hussain in the Cleavage, OR technician.
Assalamualaikum, Muhammad Swan, orthopedic staff in AQ.
Dr. Naveed, I'm consultant here in the cave.
Okay, thank you so much for the introduction. Dr. Shams, can you hear me now?
I can hear you crystal clear, but I can't hear the other, the guys who were saying Assalamu Alaikum introduction. It was not clear. You are crystal clear.
I need to be, sir. So my JD says that. So anyhow, so you see we have a combination of postgraduate residents as well as faculty, as well as we have always invited operating room technicians to be partner with us in all workshops. So they are here today. So let us begin the proceedings. First talk is by Dr. Khaled Varmusha on meniscal anatomy and function. And I must also welcome the online faculty and colleagues who have joined. Very prominent among them is our great friend, Dr. Shams Tabrez as faculty, the great name, great person. And my great friend, Dr. Amir Qureshi from UK, who's also a course faculty today. Welcome, Dr. Amir. Can you hear us?
Yes, Assalamu Alaikum. All clear.
Are you okay with the timings, Dr. Amir? 2 talks before your...
It's 5 o'clock in the morning, but apart from that, it's okay. Anything for you.
I know you're on call for the emergency, but let us know if you're pressing you for time.
The vascular consultant rang me about 40 minutes ago, but it's all sorted for now.
All right, thank you. I also welcome rest of the online faculty, colleagues, especially our colleague Dr. Malik Javed Iqbal from Peshawar. So welcome to all of them. So let's, without wasting further time, over to Dr. Khalid Shah, sir.
Assalamu alaikum, participants, Mr. Amir, Mr. Shams Tabrez और हारून साहब जो हमारे साइंटिफिक चेयरमैन है वो भी मेरे ख्याल में कहीं दूर बैठे हुए हैं. I welcome you all. Before starting, just a few words. Although I'm very grateful to Masood Umar for his kind word, but I can't take all the credit. This was a team effort that we started as a VOA Arthroscopy Forum in 2014. And with all the faculty and members of that forum, we continued with our academic activities, organized workshops almost in all the major cities of Pakistan. And ultimately, we decided to upgrade that forum to a society. And I'm quite pleased that we have achieved that target. And as Masood's mentioned, we would be launching the society formally on the auspicious occasion of 14th August. And from then onwards, all the activities would be carried out under the banner of Arthroscopy and Sports Surgery Society. I'm grateful to all the colleagues who have contributed and assisted, and although there was a wait of 2 years, but we did achieve what we aimed for. Thank you very much. Coming to the topic, word meniscus comes from the Greek word meniskos, meaning crescent, and meniscus of the knee are two fibrocartilaginous discs with unique biochemical composition and structure. The meniscus is meant to improve joint congruity. It is there to handle load transmission and also to act as a shock absorber. Meniscal injuries are a significant source of musculoskeletal morbidity, and the arthroscopic treatment of meniscal injuries accounts for almost 10 to 20% of all orthopedic injuries. This is the figure I got from Fox et al.'s review article. And the meniscal damage leads to knee degeneration. As you all know, most of these things are already known to the people attending the workshop, but this is just a refresher. Meniscus of knee are two fibrocartilaginous crescents covering medial and lateral tibial plateaus. They are anchored at meniscal horns via bony attachments at anterior and posterior aspects of tibial plateau, as you can see on the diagram. Lateral meniscus is C-shaped, and it covers about 75 to 93% of lateral tibial plateau, whereas medial meniscus is more semicircular shaped, and it covers from 51 to 74% of medial tibial plateau. If we talk about medial meniscus, it is approximately 40 to 55 millimeter long and 27 millimeter wide with AP dia of approximately 35 millimeters. Posterior region is broader than the anterior one, whereas the posterior horn is firmly anchored via bony attachment at posterior intercondylar fossa, anterior to insertions of PCL. The attachment of posterior horn is significant because of this firm attachment. The mobility of medial meniscus is compromised, and extreme positions of flexion and extra loading, it is more likely to develop tears. So the anatomy is also reflective of the problems that might occur clinically. Anterior horn is commonly attached 7 millimeter anterior to ACL. Anterior medial meniscal horn is also attached to the anterior lateral meniscal horn by intermeniscal ligament, and this is the ligament that you see on arthroscopic examination. Medial meniscus also attaches to the deep medial collateral ligament and is thus relatively immobile. As I said, that the firm attachments at the anterior and posterior horn, and then to the periphery, especially to the medial collateral ligament, the mobility of medial meniscus is quite less. Whereas lateral meniscus is C-shaped and uniform in width, anterior to posterior. Anterior horn again inserts anterior to intercondylar eminence and lateral to ACL attachment on tibia. This attachment of the anterior horn is also taken as a reference point when you are drilling for the ACL tunnels. Posterior horn attaches posterior to lateral tibial spine and anterior to attachment of posterior medial meniscus. As you see that the lateral meniscus is attached in between the anterior and posterior horns of the medial meniscus. If present, one or both meniscofemoral ligament attaches to lateral meniscus, include ligament of Humphrey and ligament of Reesburg. These two ligaments, they are attached to the inner side of the medial femoral condyle, and they again are attached to the posterior horn of the lateral meniscus. Lateral meniscus also has loose peripheral attachment to joint capsule, but it is not attached to the lateral collateral ligament. And this allows for increased mobility of lateral meniscus compared to medial meniscus, meaning that with the movement of the knee, the lateral meniscus moves along with the lateral femoral condyle, whereas the medial meniscus does not and is more liable to extra stresses and tears. If we talk about the vascular anatomy, medial and lateral geniculate arteries are branches of the popliteal artery, and they are primarily providing blood to the meniscus. A premeniscal capillary plexus provides majority of vascular supply. Supply to the meniscus, as can be seen on the lower picture. Adult meniscus is largely avascular, whereas peripheral 10 to 30% of medial and 10 to 25% of lateral meniscus receive direct blood supply. This has important implication for healing, meaning that if you are planning to repair the menisci, they are more liable to have good results if the tear is within the peripheral third. There are three distinct zones. Peripheral vascularized is called red zone, whereas there is a partially vascularized red-white zone in between, and the central, there is the avascular white zone, meaning that the tears of the central portions would not have good results with repair. To maintain their structure, white and red-white zones receive nutrition from synovial fluid by diffusion. And this is important because there is no direct supply, but the inner portions do need nutrition. And as you all know that the synovial fluid has the nutrients. So when the knee moves, the pressure of the condyles, that causes diffusion and movement of fluid inside and out. When there is a pressure on a certain part of the meniscus, the fluid inside comes out, and the area which is not under pressure, the fluid moves in. So the cyclical movement of the knee thus leads to nutrition of the meniscus, and the same applies to the cartilage of the knee. There is a misconception, or the patients most of the time tell us that we have pain in the knee and the joint is degenerating, and the doctor told us not to walk. According to this anatomical explanation, walking is good even for degenerated knees. Whatever cartilage and meniscus is left, the walking would help in its nutrition and would improve the chances of the knee lasting longer. So I always recommend them to keep walking, whether it's degenerating or not. You can think of the other treatments as well, but walking is not contraindicated. As to neuroanatomic structure, knee receives innervation from posterior tibial, obturator, femoral, and common peroneal nerve. And these nerve branches, they follow the same distribution as the vascular supply. Neural elements are mostly concentrated in peripheral third of meniscus, same as the vascularity. Additionally, there are mechanoreceptors contributing to joint proprioception. Now, this is important. Proprioception literally means the position or angle of the joint, And these mechanoreceptors, they send impulses. The mechanical loading is converted into nerve impulses which reach the brain, and they tell the brain what is the position of the knee. And the simple test would be you close your eyes and move your knee, and still you know which angle of the knee is there. So proprioception is important for stability and balance of the knee also. As to the microstructure and biochemical composition, meniscal fibrocartilage is dense extracellular matrix composed primarily of water. This is 65 to 70% water. Collagen is 1/4, and then there are proteoglycans. In white zone, fibrochondrocytes predominate. This is a combination of fibrous and the chondrocytes. And the reason is that in the white zone, the vascularity is not there. So anaerobic interspersed cells with few mitochondria are suited for poorly vascularized regions. Fibroblasts needs more vascularity, so they are in the red zone. Collagen and the microstructure. Type 1 collagen is present in the red zone, while type 2 collagen predominates the extracellular matrix of white zone. Collagen fibrils are arranged in intricate 3-layered structure, and they convert the vertical compressive load into circumferential hoop stresses. If you look at the picture of the deep layer, most collagen dense and contains more type 1 oriented circumferentially to result circumferential hoop stresses, meaning that when vertical load is applied, these circumferential fibers, they are resisting the extrusion of the meniscus peripherally. So that vertical stress is converted to circumferential hoop stress, and they resist it. Then there is the layer where the fibers are oriented radially. They are also type 1 collagen fibers. And this is the second layer. These fibers weave themselves through circumferential fibers, tying them together, providing structural rigidity, resisting longitudinal splitting. If I could give you the example, when they are putting the iron bars for these civil works, जैसे छत डल रही है या कुछ और, तो पहले वो आयरन का वो एक बनाते हैं जंगला सा, और उसके अंदर फिर सीमेंट डाला जाता है. So these collagen fibers are that kind of the iron jangla, which और उसमें जो radial fibers हैं, वो जंगला भी at 90 degrees एक दूसरे के ऊपर बांधा जाता है, तो वो एक दूसरे को tie कर रहे होते हैं. They resist the tensile forces, and when you put the cement with it, that resists the compressive forces. Its final layer is oriented parallel to surface at various angles, and it provides smooth gliding surface for the femoral condyles. Water, as I said, water comprises 65 to 70% of total weight and predominantly resides in the posterior regions. जो posterior half है meniscus का, उसमें water content जरा ज़्यादा होता है. Or the hydraulic permeability of meniscus absorbs shock and limit injury. जैसे मैंने कहा कि water जो है, इसकी एक जो property है meniscus की, वो shock absorption है. और जैसे आपने गाड़ियों के shocks देखे होंगे, उसके अंदर भी oil होता है. जब गाड़ी झटका लगता है, shock absorber नीचे जाता है, तो oil disperse होता है और वो उस shock को absorb कर रहा होता है. इसी तरह इन्होंने इलेक्ट्रॉन माइक्रोस्कोपी पर ऑब्जर्व किया है कि meniscus के अंदर भी कुछ canal like structures हैं, और these canals are probably there for ingress and out towards movement of the water. So when you land on something with the knee, उस pressure को भी इसमें से पानी निकलता है, वो absorb करता है और cartilage के ऊपर stresses decrease कर जाते हैं. The proteoglycans are located within interwoven layers of collagen found with core protein covalently attached to one or more glycoaminoglycans. These negatively charged hydrophilic molecules draw water into meniscus. Again, ये जो molecules हैं, they act as the cement. They are in between the collagen fibers और ये compressive strains भी बर्दाश्त कर रहे होते हैं. Now coming to the function of meniscus in knee joint, it improves joint congruity and stabilization. It is important in load transmission and shock absorption, and proprioception and joint lubrication is also one of the function. अगर आप इस diagram को देखें तो जो femur, ये जरा rough sketch है, मगर मकसद ये है कि femur is convex, tibia is either flat or again, if you imagine that these two bones are against one another without the meniscus, then the loading would be at only the point of contact. और ये पर यूनिट एरिया लोड जो है वो बहुत बढ़ जाएगा और जो कार्टिलेज इन कांटेक्ट होगा उस पे लोड जो है उसके अपनी स्ट्रेंथ से भी ज़्यादा हो गया तो कार्टिलेज की डीजनरेशन बढ़ जाएगी. अगर आप बीच में इसको मेनिस्कस को डाल दें तो वो सरफेस एरिया इंक्रीज कर जाता है. तो जो अगर फर्ज कीजिए 60 किलोग्राम लोड पहले 1 सेंटीमीटर पे आ रहा था, अब अगर वो 3 सेंटीमीटर पे आ गया तो वो उतना ही पर यूनिट एरिया डिक्रीज हो गया. तो इसलिए ये एडवांटेज मेनिस्कस की जॉइंट कंग्रुएटी इंप्रूव करने से है. और फिर दूसरी स्टेबलाइजेशन भी इसी की तरह है. अगर ट्रक आप कहीं उस पे चढ़ाई पे खड़ा कर दें तो उसके पीछे भी वो एक वेज लगा देते हैं टायर के पीछे कि ये स्लिप ना कर जाए. So as I said, due to mismatch of convex femoral condyle and slight concavity of medial tibial plateau, the contact area is small without the meniscus, and wedge-shaped cross-section and its semicircular shape allow the meniscus to fill in the empty space between plateau and condyle. Stabilization. There are various attachments of medial meniscus, provide strong stabilizing force and allows for minimal translation. अगर ये मेनिस्काई की अटैचमेंट्स ना होती तो जब भी लोड पड़ता तो ये बोन में से स्लिप कर जाते. तो ये जो स्टेबलाइजेशन हो रही है डिफरेंट स्ट्रक्चर्स के साथ अटैचमेंट के लिए, तो वो इसकी स्टेबिलिटी बढ़ाने के लिए कि वो वेज जो है वो स्लिप ना करे. Lesser attachments or lateral meniscus allows greater degree of anterior and posterior translation of lateral femoral condyle over tibia, but maintains its orientation around the condyle with its mobility. जब movement होती है, medial meniscus इतना move नहीं कर रहा, lateral move कर रहा होता है, मगर वो condyle के साथ साथ move करता है. तो वो जो अपने function है congruity के और load bearing और transmission के वो साथ साथ perform करता रहता है. Absence of functional medial meniscus in an ACL deficient knee demonstrates up to 58% increased anterior tibial translation compared with ACL tear alone and worsened pivot shift. तो आप इमेजिन करो कि अगर ACL इंजरी है और साथ ही medial meniscus भी नहीं है तो फिर वो जो wedge की सपोर्ट होगी वो भी नहीं होगी, तो pivot shift भी ज़्यादा exaggerate हो जाएगा और उसकी degeneration भी ज़्यादा तेजी से होगी. After meniscal transplantation or repair, tibial translation is returned to pre-meniscectomy levels. ये सिर्फ दिखाना चाह रहा था कि जिस तरह हमारी नी में स्टेबिलिटी है, ये मैं जा रहा था एक बच्चे ने ये जो भैंसे बांधते हैं ना गांव वगैरह में, उसके ऊपर इसमें दोनों जो लकड़ियां इनके अंदर कोई कनेक्शन नहीं है, मगर बच्चों ने इसको ऐसे बैलेंस किया हुआ है, सीसॉ के तौर पे भी इस्तेमाल कर रहे थे और ये बच्ची इनको धक्का दे के गोल गोल घुमा रही थी. और ये बच्चों की इंजेन्युइटी है, ये किसी ने उनको सिखाया नहीं है, उन्होंने 2 लकड़ियां पकड़ के तो अपनी खेल बना ली। तो आप लोगों से भी गुजारिश यही है कि साइंस कहीं ख़त्म नहीं होती, आप अपने आइडियाज़ भी दें और इसको और डेवलप कराएं इसी तरह से जैसे ये बच्चे अपने खिलौने बना लेते हैं। थैंक यू वेरी मच। वीडियो में तो है।
Okay, any questions to Khaled sir? Very important talk on function, anatomy, and how the meniscus works, and what are the important roles meniscus plays in knee range of motion.
My question is, if you remove the menisci and don't repair, what are the chances of degeneration in the joint? How much it increases?
As I said, if you remove the meniscus, then you do not have the same kind of load transmission. जो एक बात बता रहा था कि लोड पर यूनिट एरिया इंक्रीज कर जाएगा। अब जिस एरिया का लोड बढ़ता है, कार्टिलेज की भी एक फाइनाइट लेवल है स्ट्रेंथ लोड विथस्टैंड करने की। तो अगर आपने दोनों मेनिस्कस निकाल दिए तो वो पॉइंट लोडिंग होनी शुरू हो जाएगी। उस पॉइंट लोडिंग से वो वाला कार्टिलेज और तेजी से घिसेगा, और जो उसने फर्ज करें 10 साल में घिसना था वो 5 सालों में हो जाएगा। और यही चीज डिफरेंट एक्सपेरिमेंट्स हैं उन्होंने दिखाई कि अगर आप मीडियल मेनिस्कस निकालते हैं ACL के साथ डेफिशिएंसी के साथ तो 58% इंक्रीज चांसेस हैं डीजेनरेशन। और अगर वो आप रिपेयर कर दें तो फिर आप लोडिंग वापस नॉर्मल पे ले जाते हैं तो नेचुरली डीजेनरेशन के चांसेस कम हो जाएंगे।
मेरा क्वेश्चन ये था कि प्रीवियसली नॉर्मली जो मेनिस्कस रप्चर हुआ तो निकाल देते थे। विद द एवोल्यूशन ऑफ टाइम नेचर ने हर चीज किसी मकसद के लिए बनाई है, तो उन्होंने कहा कि इसको प्रिजर्व करना ज्यादा बेहतर है। तो ये जो रिपेयर है ये कब स्टार्ट हुई?
रिपेयर की हिस्ट्री तो मेरे ख्याल में नवीद आपको ज्यादा बेहतर पता होगी।
Repair started after 1992. Before 90s, most of the arthroscopist surgeons removed the meniscus. And the famous arthroscopist surgeon is the simile. We are using the simile knife. The simile was the pioneer for the arthroscope and very famous arthroscopist surgeon. And he died in 1992. And after that, and in 80s, I think the repair was started. Till his death, he always removed the meniscus. And knife was very famous, similes knife.
Any other question from participants? Function में एक और चीज जो I can ask everybody, understand what is the hook stress? What do you understand by hook stress? Dr. Harun Kasi, what do you understand by hook stress? What forces applied on weight bearing? Right? These are axial forces. Axial forces are
वो जो आपको एक्सप्लेन कर रहा था कि मॉर्फोलॉजी कोलेजन फाइबर्स की, तो डीप लेयर में दिखाई थी कि सर्कमफ्रेंशियल ओरिएंटेशन होती है। जैसे मसूद कह रहे हैं, जब आप एक्सियल लोड अप्लाई करते हो, ये एक्सियल लोड मेनिस्कस को ऊपर जो फोर्स आती है इसको कन्वर्ट कर रहा होता है हॉरिजॉन्टल फोर्सेस में, यानी कॉन्डाइल के प्रेशर से मेनिस्कस जो है वो बाहर की तरफ मीडियली और लेटरली स्लिप आउट होगा अगर उसके इर्द गिर्द कनेक्शंस ना हो। तो आपकी वर्टिकल लोडिंग ने उसको हॉरिजॉन्टल फोर्स में कन्वर्ट किया है। उस हॉरिजॉन्टल फोर्स को रेजिस्ट करने के लिए सर्कमफ्रेंशियल फाइबर्स हैं जो एंटीरियरली और पोस्टीरियर हॉर्न्स में फिक्स हुए हैं। तो जब उनके हॉरिजॉन्टल फोर्स पड़ती है वो बाहर को एक्सट्रूजन बनाने लगते हैं। ये जो हॉरिजॉन्टल फोर्सेस हैं जो बाहर को पुश कर रही हैं उसे हुक स्ट्रेसेस कहते हैं। ये बैरल्स भी अगर आप देखो तो उन्होंने जब बैरल्स बनाते हैं तो उनके इर्द गिर्द वो लोहे के कड़े लगाए होते हैं। अब वो जो फेमस रियर बैरल्स हो गई या दूसरी हो गई, उनमें इसी तरीके से कंस्ट्रक्ट करके उसके भी रूट स्ट्रेसेस को रेजिस्ट किया होता है।
So everybody should have good idea what are root stress is very important to meniscal function. जैसे खालिद साहब ने कहा, it's very well explained. इस बारे में किसी को कोई सवाल root stresses क्या होता है? And that would also add to Dr. साहब's question कि meniscectomy जितनी आप करते जाएंगे उतना आप लोड और इस root stress को डिक्रीज करते जाएंगे, स्पेशली रिपेयर की जो बात है, स्पेशली जो रूट रिपेयर की अपनी हमारी टॉक की आमिर साहब की, अगर हम रूट्स को रिपेयर नहीं करेंगे, रूट पे दो जगह एंकर्ड है मेनिस्कस और बाकी कैप्सूलर अटैचमेंट, अगर एक रूट उखड़ जाएगा तो सारे स्ट्रेस जीरो हो जाएंगे। मेनिस्कस ऐसे स्प्रे की तरह बाहर को चला जाएगा और सारा लोड कार्टिलेज पे आ जाएगा और डिजनरेशन शुरू हो जाएगी। अब जैसे खालिद साहब जो मुझे याद है कि लैटरल मेनिस्केक्टमी की डिजनरेशन ज्यादा होती है, तो लैटरल tibial plateau is convex, medial tibial plateau is concave, तो उसमें इतनी नहीं होती, वो पहले ही थोड़ी सी डिश है, लेकिन लैटरल tibial plateau is convex, इसलिए जब आप लैटरल मेनिस्केक्टमी करते हैं उसकी डिजनरेशन ज्यादा है और जितनी ज्यादा करेंगे मेनिस्कस निकालेंगे उतना ज्यादा डिजनरेशन। तो आज की हमारी सारी वर्कशॉप की थीम रिपेयर पे है, तो ये मैसेज लेके जा रहे हैं यहाँ पे कि पहली बात कि रिपेयर किया जा सकता है, किस किस को रिपेयर किया जा सकता है और रिपेयर कब कब किया जा सकता है, किन किन कंडीशन में। आई होप कि बिफोर यू लीव द हॉल टुडे ये ऑब्जेक्टिव्स क्लियर हो जाएंगे। तो आगे बढ़ते हैं। सो ओवर टू डॉक्टर इरफान राज।
Very much, sir. So already we discussed in detail the anatomy of the meniscus. The medial meniscus is larger, semilunar, and the lateral meniscus is shorter and C-shaped. The menisci contains 70% of the collagen type 1 and extracellular matrix, proteoglycans, and glycoproteins. Around there are 12 ligaments that attach the medial and lateral meniscus, and ligaments that attach medial lateral meniscus to the tibial plateau. The most important is the anterior intermeniscus ligament that is attached anteriorly on the anterior horn of the medial and lateral meniscus. Another two important ligaments that attach the medial and lateral meniscus, the coronary ligament and the tibial insertion ligament. The coronary ligaments attaches the meniscus of periphery of the meniscus to the tibial plateau, and the tibial insertional ligaments attaches the anterior and posterior horn of the meniscus with the tibial plateau. The most important ligaments, the posterior aspect of the knee, the meniscofemoral ligament, those are anterior and posterior meniscofemoral ligament. According to the attachment side regarding the posterior cruciate ligament, if the ligament which is attached anterior to posterior cruciate ligament, that is anterior meniscofemoral ligament, the ligament of Humphrey, and the posterior to the posterior cruciate ligament, that is the ligament of Risberg. And these ligaments provide constrained posterior translation of the tibia over the femur. And in deficient knee, in PCL deficient knee, these ligaments having important work for the posterior translation of the tibia. As we already know, the deep medial collateral ligament attaches the medial meniscus. I'm not going into detail. The functional biomechanics of the menisci or the load distribution is already discussed by Kam Shah Saab. Is provide stability of the knee and meniscal motion during knee motion. The concerning the load transmission, 70% load transmitted in axial loading at the lateral compartment on the lateral meniscus side, and 50% load transmitted on the medial meniscus side. It is important the posterior translation of the lateral meniscus is greater than medial meniscus. As we already discussed, the mobile meniscus is lateral meniscus as compared to medial meniscus. Because of this, the medial meniscus is most torn because it is rigid part of the knee. Whenever there is an injury occur with ACL, the medial meniscus is most commonly injured. Why? There is a play is less as compared to lateral meniscus. In ACL deficient knees, the medial meniscus also provides the constraint for the anterior translation of the tibia in ACL deficient knees. Generally, considering all meniscus lesion in different sports, the medial meniscus is affected 24% of the cases. The lateral meniscus around 8%. 20-30% of meniscus lesion are associated with other ligamentous injuries like PCL, ACL, and collateral ligaments. The valgus impact with external rotation of the tibia is the most common cause of meniscal injuries along with ligaments. We can appreciate the joint inward force causing the medial collateral ligament injury. The joint outward forces causes the lateral collateral ligament injuries. And if the fixed part of the foot is fixed on the ground and there is a torsional effect moving upper body, there is a causing the sprain of the ligaments, maybe ACL, PCL, and meniscus. In hyperextension of the knee, collaterals and cruciate ligaments mostly torn. So the meniscal tears are more common in young and active individuals, particularly when enrolled in level 1 sports activities like soccer, rugby, and football. Tears of the normal meniscus occur 80 to 90% of the cases following sports injuries. Traumatic meniscal lesion on normal meniscus are either isolated or associated with the ACL or PCL. Injuries in athletes mostly involve the anterior cruciate ligament, that is about 20%. And after the ACL, the medial meniscus, that is 10.76%, and then lateral meniscus, that is 3%. Delayed ACL repair for more than 12 months, this is important. The delayed ACL repair for more than 12 months after ACL injury determines an overall odd ratio of 3.50 for medial meniscus tear. It means if we delay the ACL repair more than 1 year, there is a maximum chances of the medial meniscus that was not already present. The medial meniscus are found in 36% to 47% in tibial plateau fractures. According to Stansky, 45% of children and adolescents with hemarthrosis have a meniscal tear, of which 3/4 have a lesion of the ACL. Up to 70% of ACL tear in children are associated with meniscal lesion. The meniscal lesion may also secondary to chronic laxity, as we have a congenital laxity in the joints having chances of the meniscal tear. The clinical presentation of the meniscus are pain and swelling around knee. This is the most clinical picture. Unable displaced tear might lead to mechanical symptoms such as clicking, locking, and catching sensation. So at the end, we diagnose the meniscal tear on the basis of detailed history and examination. And at the end, we need MRI for confirmation of diagnosis. Now, the actual topic of my presentation is classification of meniscal tears. The meniscal tear can be classified in various ways according to anatomy and by proximity of the blood supply to the meniscus. The functional importance of these classification ultimately helps surgeons determine whether a meniscus is repairable or not repairable. Classification according to vascularity. Miller, Warner, and Harlan classification, very famous classification. According on the periphery, there is a most vascular part, and inner side of the knee, there is a avascular part. And according to vascularity, they classify red zone, red-white zone, and white-white zone. If tear occur in the periphery, in the red zone, there is a increased chances of healing. If there is a tear in the white zone, there is a very chances of the repair and According to tear types, O'Connor classification is very famous, and in 1992, he classified the meniscal tears, longitudinal tears, horizontal tears, radial tears. We will discuss in details. The longitudinal tears are the most frequent injuries due to trauma, represent 29% of all meniscal lesions and 33% of all lateral meniscus. The bucket handle tear is the type of longitudinal tear when it extends from anterior to posterior and the inner fragment displays intracondylar area. This becomes bucket handle and catching and locking sensation occur clinically. The radial tears are very unstable tears. It start from inner side of the body and goes from towards periphery. And these are very, very unstable and must be repaired. The flap are parrot beak tears. Usually they are radial tears with circumferential extension, creating a flap of meniscal tissues. So I am not discussing the treatment. We will discuss later on by my colleagues. The horizontal cleavage tears, mostly these tears are degenerative tears in old age. The complex degenerative tears, mostly these tears is also present in the old age due to osteoarthritis knees. The meniscal root lesions, either by traumatic or degenerative. Traumatic meniscal root lesions are often combined with ACL tears, particularly on the lateral meniscus. This is important that discoid meniscus mostly present in adolescent age. The discoid meniscus is meniscal abnormality whose origin remains unknown till now. Discoid lateral meniscus has been first described by Young in 1889. The prevalence is estimated between 0.4 to 16%, being more frequent in Asian populations. The anomaly mainly concerns the lateral meniscus, but few case reports are also present for the medial meniscus discoid. The disease is bilateral in 5 to 20% of the cases. This is the classification of the discoid meniscus. Watanabe in 1978 described these meniscus lesions. The type A, type 1 block shape. On A slide, there is a type 1 block shaped stable complete meniscus. Type B partial meniscus but stable, and type C is unstable, mostly discoid lateral meniscus arising from the ligament of the wrist curve. Now the recently classification is made by the International Society of Arthroscopy, Knee Surgery and Orthopedic Sports Medicine on the meniscal tears. They describe the meniscal tears on the basis of tear depth, location, radial location, central to popliteus hiatus, quality of tissue, tear length, and percentage of meniscus excision. In tear depth, if we look, tear depth may be partial or complete. Location in zone 1, zone 2, zone 3. Radial location may be in the anterior portion, in the mid body, and the posterior portion. And center to the popliteus hiatus on the lateral meniscus is present, tear present or not present. The tear pattern, same in the tear types. We already discussed the longitudinal, horizontal, radial, vertical, these tear sites. The committee discouraged the use of terms red, white, and white because the vascularity of the meniscus changed from prenatal, natal to till death. So they agreed on this. You classify the meniscus on the basis of the zones, on the basis of the tears, on the basis of the excision of the meniscus. Thank you very much. Any question regarding the meniscal tear?
Any questions on the types of tears?
Masood, can I ask a question, please?
Yes, please, sir. Malik Javed Saab from Peshawar.
Yeah, very good lecture from from the classification and the lesions of the meniscus. But I was wondering, I think is the MRI classification, I think, which is more important because most of the decisions are being made on those MRI classification. So I think a little bit of light on those, on that classification would be helpful. MRI classification of the.
वो शम्स साहब आ रहे हैं सर एक प्रेजेंटेशन देके.
Okay, thanks very much. Sorry about that. Sorry. Okay, sorry about that.
लगाई है. So, but thank you for preempting our colleague. He will be better prepared for this question now. Any other questions from the house? Everybody understand what is the bucket handle here? President?
It is not clear that radical and bucket handle are differential.
Radial tear is a start from inner part of the body and goes to the periphery. This is the radial. Longitudinal tear from anterior to posterior or posterior to anterior in the vertical. The longitudinal is the vertical. Radial is just like this. This is radical tear and this is longitudinal. So now the question asked by Professor Masood, what is bucket handle tear? Have you understand what is bucket handle tear? Yes. The vertical oriented extending from the inner edge of the meniscus towards its periphery. This is the radial.
Longitudinal ये है.
Can we say that one is the coronal plane and the other is the sagittal plane injury? The radial runs in the coronal plane.
Yes.
From medial to lateral, and the other is in the sagittal plane along the axis of the meniscus. That's why कि वो bucket handle जब होता है तो वो intercondylar notch में आ जाता है और उसके बाद वो locking और catching और सारी symptoms.
You can appreciate the inner edge of the meniscus is coming internally in the intercondylar region, and the periphery is attached at the peripheral region of the knee. So whenever there is a flexion knee occurs, the condyle, medial condyle or lateral condyle rub with the platotibial plate. Now in flexion, this tears displaces medial, and when the patient try to extend his or her knee, they have a complaint, catching or locking. Suddenly they stop. Why? Because of the condyle of the femur is stuck with the tibial plate between the two flaps, the inner and the outer. So the total of the knee, they again, the dislocated part of the meniscus again relocated on its same size, and the patient is comfortable. जब डॉक्टर साहब में ठीक हो गई.
एक और एक्सप्लेनेशन है, अगर आप वो बकेट का हैंडल देखें, जैसे अभी बता रहे हैं इरफान, वो बकेट का हैंडल आप ऐसे ऊपर उठाते हो और वो वापस जाके सर्कमफ्रेंस पे गिर जाता है. तो वो इसी वजह से इसको बकेट हैंडल कहा गया है कि ये ऊपर को उठ जाता है और जैसे उन्होंने बताया इसके दरमियान में कॉन्डाइल फंस के लॉकिंग करा सकता है.
So any comments or additions to this from the online faculty?
Bucket handle, they must understand, जैसे शाह साहब ने कहा, what is a bucket? पहले तो ये दसो, ठीक है ना? So you must see when you go home that bucket और उसका handle किधर बाल्टी का पड़ा होता है.
शावर से नहाते हैं.
जी बिल्कुल, I still do that. वो जो handle है, that is sitting on the position जो कि normal होती है, कि वो लेटा होता है उसके ऊपर. That is the normal position of meniscus as well. When there is a tear, what we call bucket handle, what happen? Why we call it? Because ये जब handle को आप उठाते हैं, वो center में आ जाता है. तो जो bucket handle tear by definition, when the meniscus जो torn bit है, is in the notch. Am I right, Masood Umar?
You can never be wrong.
उस वक्त इसको bucket handle tear कहते हैं when the handle is right up in the center, which is the intercondylar notch. तो उस वक्त इसको है, तो इंशाल्लाह मेरे पास एक slide है, I'll show you in my.
So डॉक्टर साहब आपको समझ आ गई? इट इज एन एक्सटेंडेड लॉन्गिट्यूडनल टीयर, राइट? लॉन्गिट्यूडनल टीयर जब बहुत एक्सटेंसिव एंटीरियर और पोस्टीरियर हॉर्न के करीब आ जाएगा तब वो इस तरह, जैसे शम्स ने और खालिद साहब ने, इरफान भाई ने बताया, वो इस तरह बकेट हैंडल की तरह उठ जाएगी। सो एसेंशियली इट इज ए लॉन्गिट्यूडनल टीयर, ये बस आपने समझ लेना। एक्सटेंसिव लॉन्गिट्यूडनल टीयर एक तो छोटा एरिया में हो गया, दैट विल नॉट बिकम ए बकेट हैंडल क्योंकि उसकी अटैचमेंट है। जब वो बिल्कुल एक्सटेंसिव हो जाएगा फिर वो एक इस तरह बकेट हैंडल की तरह जैसे बताया गया। So radial tear is perpendicular to a longitudinal tear, ठीक है? ये जहन में बिठा लें, 2-3 बातें, रेजिडेंट्स कंफ्यूज हो जाते हैं। हॉरिजॉन्टल टीयर इज अनदर प्लेन टीयर, ठीक? बिल्कुल जैसे आप डबल रोटी को स्लाइस करते हैं ना, ठीक है ना, उस तरह हॉरिजॉन्टल टीयर, जैसे आप इमेजिन करें छुरी से आप मेनिस्कस को ऐसे काट रहे हैं, हॉरिजॉन्टल टीयर। तो ये तीन
बात हो रही है कि different planes are coronal, sagittal, and axial. So remember, coronal goes with the longitudinal, sagittal goes with the vertical, and the axial goes with the horizontal. So it's going to have to understand कि कौन से plane की बात हो रही है, तो what can be done. That is one way response.
Which one is difficult to see on arthroscopy? Which tier? Longitudinal, vertical or horizontal? ये बच्चों से पूछें।
बच्चों ने ज्यादा लोगों ने कहा horizontal.
Yes, they are right. Or which are normally missed? These are the one which are missed by quite few famous surgeons. They are easily missed, horizontal tears.
सही है, सही है। तो सवाल आया जावेद साहब का कि MRI पे तो नजर आ जाएंगे ना?
MRI पढ़नी आएगी तो नजर आएंगे। MRI is operator dependent.
तो हाँ जी, any other question on tears? Types of tears, injuries associated. वो टाइम मिला तो वो वीडियो चलाएंगे। मैकमरे टेस्ट कैसे करते हैं वो रह गया कंपोनेंट मेरे भी ध्यान। असल में हम रिपेयर की तरफ ज्यादा फोकस, जूनियर रेजिडेंट भी हैं यहाँ, हाउ टू डू ए गुड मैकमरे टेस्ट, राइट, फॉर द क्लिनिकल डायग्नोसिस। ये रेडियोलॉजी पे तो हम बाद में जाते हैं, पहले क्लिनिकल डायग्नोसिस, क्लिनिक में मरीज आता है, पेन हो रहा है, इंजरी की हिस्ट्री है, और इसी तरह आपके एग्जाम में आता है तो लड़कों को वहां मैकमरे टेस्ट नहीं करना आता। वो उसको देखें, बहुत बुनियादी टेस्ट है ना नी एग्जामिनेशन का, कि पेशेंट को रिलैक्स कैसे करना है, मीडियल और लैटरल मेनिस्कस को क्लिनिकली जज कैसे करना है कि टीयर है या नहीं। सो अगर किसी फैकल्टी के पास वीडियो है तो हम बीच में चला देंगे, एंड पे चला सकते हैं। इवन डॉक्टर आमिर, इफ यू हैव दैट वीडियो तो आप उसमें एंड पे दिखा दीजिए। Anybody has?
I do have a couple of videos in my presentation.
All right. So I think let's move on. अच्छा, interesting addition ये हुई है कि जो मैंने इस प्रोग्राम में नहीं लिखा, वो एक MCQ टेस्ट जनरेट हो गया है, हमारे इंस्ट्रक्टर और सीनियर रेजिडेंट ने कर लिया। So जैसे ही रेजिडेंट सोने लगेंगे तो हम MCQ टेस्ट चला देंगे, ठीक है ना, 20 नंबर का। तो वो ऑनलाइन होगा, वो अभी हम मेरा ख्याल टी ब्रेक के फौरन बाद जब ताज़ा दम होके आएंगे फिर चलाएंगे, फैकल्टी के लिए ऑप्शनल होगा। ओवर टू यू शम्साब। शम्साब, as he was introduced initially, he will take us through the radiology of meniscal injuries. Initially मैंने कहा इनको कि रेडियोलॉजिस्ट को मैं बुला लेता हूँ, लेकिन he insisted कि no, he will take this challenge and take us through the radiological signs, एक्सरे, MRI जो भी हैं उनके थ्रू चलेंगे। अच्छा, we have good about 20 participants online also. That is heartening to know. नहीं वो और वो पिछली। So any questions from any participants? You're also welcome. I see our great friend Dr. Zahid Askar online also. Welcome, Dr. Zahid.
बिस्मिल्लाहिर्रहमानिर्रहीम। ये मैंने इसलिए कहा है कि मैं ऑडियंस से पूछना चाहता हूँ कि अगर आपने फ्रैक्चर एंकल को फिक्स करना है, if you're going to fix the ankle, would you see the x-rays first?
हाँ जी, yes आया जी.
Yes.
जी, अगर आपको, if you don't know how to read the x-ray, would you go for the operation?
No.
No.
Yeah. If you take my message today, my talk will be finished and I'll be grateful to you guys. Do not, please do not operate if you don't know if you don't know how to read the MRI scan for meniscal tear. आप agree करेंगे?
Yes.
अगर आपको MRI scan पढ़ना नहीं आता, do not operate on meniscal tear, whether meniscectomy or repair. You must learn how to read MRI basic. और मैंने 2-3 स्लाइडें दिखानी है और कुछ नहीं मैंने दिखाना ताकि आपको कॉन्सेप्ट हो जाए. I'm not going to show you ACL, PCL, anything. Just 3 slides of menisci, how to read it, how to see it. तो मेरा बस ये मैसेज है, kindly if you take it home कि आपने ऑपरेट नहीं करना ये वर्कशॉप करने के बाद कि जी हुण मैनू आ गया तो I'm going to do it. No. You must know how to read it. That's my message for today. ठीक है जी, ये एक है, this is purely for Masood Umar. मौलवी हरगिज नशुद मौलाए रोम ता गुलामे शम्स तब्रेजी नशुद. नीचे वो लिखा हुआ है कि you should become, you know, I should be your spiritual guide, Masood Umar.
You are, sir.
I am graduate of 1986 in the center. That's my principal late, and on his right, the guy in beard, a slight good-looking guy. That's me.
वो कर्सर लगाए ना, आप नजर नहीं आया, वापस क्या है?
वो मुझे ये हूँ मैं. Can you see?
That is the left one. Right.
ये हमारा right.
Yes, yes.
मेरा right, उनका left.
हाँ जी.
They were, this college was 1974 का college है, MIT का था दाखिल. This is Shams Tabriz and this is Shams Tabriz. There were 2 Shams Tabriz in the college in the history, और अभी तक तीजा कोई नहीं आया. These were my 2 teachers. He was Mr. Alam, great guy, excellent. इसका कभी आप देखें तो भरा हुआ है इसका नी के बारे में, scopes के. And this is Ian Ritchie. He was president of Royal College. I worked with him. Anyway, Ji, this is the thing you need to know. I don't need to teach you the basics of MR, but you need to have 3 views, which is coronal, sagittal, axial. ठीक है जी, ये सामने आपके पड़ा हुआ है. This is coronal. ठीक है, इसमें सब कुछ लिखा हुआ है कि ये कौन सी साइड है, ये कौन सा है, ये meniscus है, ये है. ठीक, you need to know this. So keep in mind this is coronal. Then this is sagittal. ठीक है जी, beautiful. ये आपके जो क्या होता है meniscus है. ठीक है जी, ये we'll discuss in a minute. So and this is the third one, axial. ठीक है जी, वो भी मैं सुन रहा था, कोई कह रहा था कि ये जो है coronal पे नजर आता है, the other one is on sagittal and the third one is on axial. For you guys, you must know all the 3. There are 3 views, और उसको कैसे interpret करना है. So, I hope to God when you're going to read about MRI scan, you should know what is T1 and what is T2 images, what is PD, what is FS fat suppression को है. ठीक है जी. Then you also know कि white किस में आता है fluid और gray किस में है fluid. So this is medial meniscus. This is T1 and this is PD FS जो भी है ये. If you look at it, this is, इसमें एक चीज आपने देखनी है, sharp edge. So this is, I presume, medial meniscus, beautifully shown here. There's a sharp edge and you can see इसकी shape जो है. I will request you guys look at this now and then I'll show you another slide and then you should know the difference. This is all black. Can everyone see it? खालिशा साहिब,
क्या सवाल है दोबारा करें?
Umar,
जी जी.
can you ask the guys, can they see this shape?
Black triangle, yes, all of them can see very clearly.
Can you see it?
Yes, yes, we can.
ठीक है जी, ये मैंने एक वैसे बीच में ITB का भी डाल दिया कि this is iliotibial band. Then you will know this is lateral side, this is medial side. Okay? अगर आपको नजर नहीं आ रहा, कोई और चीजें भी होती हैं जिससे आप medial और lateral का कर सकते हैं. So this is a band ITB, and obviously then this is lateral and this is medial. ठीक है जी? So these are normal shapes on coronal images, on T1 and PDFS images. ठीक है जी? Now, anyone can see the difference here, here, and this one. This is pure black, this is pure black. And look at this. Look at that.
डिफरेंस देखा क्या डिफरेंस? हाँ, व्हाइट लाइन जो आ रही है दैट इज
MRI क्या होता है? सिग्नल चेंज. सो मैं इतने प्यार से बता रहा हूं कि ये इफ यू लुक एट दिस ओनली you will not miss anything. ठीक है जी? It is so simple to read it, लेकिन हम लोग भागते हैं, डरते हैं. सॉरी, ये इस साइड पे इस तरह दिखाया हुआ और जो वो चेयर है वो slightly different. But this is pure black. No signal change. There's nothing, no white, nothing. ठीक है जी? No gray thing. Now look at this. I hope you can appreciate it.
Yes, this is lateral meniscus.
Yeah, वो थोड़ी सी गलती होगी, दूसरा देता. Anyway जी,
जरा बता दे, एक मिनट. आपने जो ये पहली स्लाइड दिखाई है, इसमें आप बात कर रहे थे आइडेंटिफाई करने का कि मीडियल कौन सा है और लेटरल कौन सा है. जी. उसमें जरा एक दो पॉइंटर्स इन्हें बता दें. लेंथ ऑफ द मेनिस्कस जो कि टिबिया को कवर कर रही है, वो भी एक इंडिकेशन हो सकती है.
बिल्कुल बिल्कुल.
मेनिस्कस ज्यादा कवर कर रहा होता है तो लंबा होगा.
मैं इसलिए बाकी चीजों में जाना नहीं चाह रहा था कि सिर्फ मैं दो चीजें बताना चाहता हूं. चेंज ऑफ सिग्नल, दैट्स इट. इनको मीडियल लैटरल तो पता लग जाएगा ना. जैसे मसूद ने कहा, you should see the patient, take the history and examination. आपका diagnosis उसी वक्त होना चाहिए. MRI is to confirm it. Right. Am I right? Yes. You must take the history. जैसे locking होती है, जैसे जो भी history है, कब हुआ, swelling कब start हुई, within an hour हुई or within 24 hours हुई, you know, all the indications. So at this level, if you are a postgraduate, person, you should know history is important. 30% आपका diagnosis history पे हो जाता है. Then you do examination, उस पे भी हो जाता है. And your diagnosis is there. Because now if we operate, we must have the evidence, because it's 21st century, it's evidence-based medicine. And what is evidence we have got is MRI scan. And then you don't, please listen, you don't rely on the report. You must know how to read it. अब ये मुझे कोई बता दे, ये क्या मुश्किल है इस टीयर को देखना? नहीं है. You know, so medial lateral और बहुत सारे indications हैं, लेकिन patient का पता होगा कि दर्द inner side पे या outer side पे है. And I'm sure ये हो जाएगा. इसमें वो किसी ने बात की थी protrusion की, अभी मेरे faculty में मेरे ख्याल आमिर ने शायद की. If you look at it, look at this picture. खालिद साहब सवाल पूछ लें बच्चों से, कोई थोड़ा सा, एक तो ये चिट्टा चिट्टा नजर आ रहा है. Can they tell the position of the meniscus? Is it in the right place?
हाँ, इसको क्या कहेंगे? एक्सट्रूडेड. ये
Yes.
टैटो से स्लिप करके बाहर चला.
अब ये मैंने इसलिए लगाई कि you must know when you are looking at the MRI scan for your own sake. ये आप देखें फीमर का और इसका एंड है, तो इसको इधर खत्म होना चाहिए था, ठीक है, लेकिन ये बाहर आया हुआ है. ये आप देख लें, ये एंड है, इसी की लाइन स्ट्रेट में ये चला आ रहा है, ठीक है जी. बट इफ यू लुक एट दिस वन, दिस इज बिट आउट, और बीच में इसके देख लें, यू नो, यू कैन सी द वाइट थिंगी एंड ऑल दैट. एक बहुत कॉमन चीज है जो रिपोर्ट में कहते हैं कि इसको जाना चाहिए, इस सरफेस को क्या कहते हैं?
कन्वेक्स.
नहीं, दैट इट शुड रीच द आर्टिकुलर सरफेस, ठीक है जी. ये जो टीयर है, जो वाइट सिग्नल है, अगर सीधा बीच में रहता और नीचे नहीं आ रहा तो ये टीयर नहीं है. मैं हमेशा लड़ता हूँ रेडियोलॉजिस्ट से. Clinically, if you have made the diagnosis and you see the signal change, it is meniscal tear. We won't go into that controversy at this level. ठीक है जी, जो बच्चे देख रहे हैं, this is extruded one. ये थोड़ा सा अगर आप ज़हन पे, आपके ज़हन में, in the back of your mind, if this is the thing कि यार ये edge जो है क्या वहीं पे है या थोड़ा बाहर आया हुआ है, तो ये आपके अगर ज़हन में होगा तो you will pick it up. ठीक है जी. एक आपने वो देख लिया टीयर, ये वाला, एक आपने ये देख लिया. अब आ जाइए जो जिससे हमारे सारों के पांव कांपते हैं, वो ये है. शाह जी, कैन यू आस्क समवन के इधर कुछ है? कैन दे सी एनीथिंग?
क्या जी? हाँ, आंसर है कि सिर्फ रिम नजर आ रहा है.
वेरी गुड. सो यू कैन सी इट हियर टू. ठीक है. अब ये चीज क्या है? ये
जवाब आया बकेट हैंडल.
गुड वन. लिखा हुआ है. दे आर इंटेलिजेंट, दे आर कराची के हैं सारे, तो इन सबको पता है हाउ टू. नहीं, I'll say nothing. So एक चीज ये देख लें आप लोग काइंडली कि ये बकेट हैंडल मतलब बहुत इंपॉर्टेंट है. इफ देयर इज समथिंग मिसिंग हियर, ब्रेन, आपके बैक ऑफ योर माइंड शुड बी बकेट हैंडल एंड देन लुक इन द नॉच. वो इसीलिए मैं कह रहा था जो बकेट हैंडल इज फाइन, नॉर्मल होता है, बट बकेट हैंडल अगर सेंटर में आ जाए तो एबनॉर्मल है. ठीक है जी. टीयर. ठीक है जी. अब महसूस आप कहेंगे एक और डबल साइन होता है, कुछ होता है, तो वो भी दिखा देते हैं. जरा पूछिएगा दोबारा, ये क्या है? व्हाट इज दिस वन?
ये क्या है जी? ये कह रहे हैं ये डबल पीसीएल.
डबल पीसीएल. नहीं, मैंने खाली इस पे कह रहा था. ये क्या है? ये पीसीएल है. ठीक है. ठीक है. और फिर ये डबल वाला, ये इतनी अच्छी पिक्चर नहीं है इसमें, साइड वाले में है वो. मैं इनको पता नहीं कैसे, मेरी सारी फोटो इस साइड पे मेरी अपनी आ रही है. सो दिस इज डबल पीसीएल साइन. क्यों? कि नॉच में पड़ा हुआ है पीसीएल पीछे इधर, और उसके आगे ये लेटा हुआ है. सो देयर टू. आई होप कि समझ आई है.
ये नीचे वाला बकेट हैंडल, ऊपर वाला पीसीएल.
ये पीसीएल है, इसके आगे यहाँ कुछ नहीं होना चाहिए. तो ये भाई साहब लेटे हुए हैं. दिस इज योर बकेट हैंडल. अब आ जाइए, बड़ा प्यारा सा, ठीक है ना. ये मिस नहीं होते, ना स्कोप पे मिस होते हैं, ना स्कैन पे मिस होते हैं. अब आप देख लें, शाह जी पूछ लें किसी से, ये क्या है? ये बीच में, इसको सिग्नल चेंज कहते हैं. कैन दे अप्रिशिएट इट?
और इसको देखकर जो इरफान बता रहे थे टीयर्स की टाइप, ये कौन सी टाइप होगी? हाँ ठीक
क्या बोला है? ठीक। अब ये ज़्यादा पीडी है, वो फैट सप्रेशन और ये चीज, कैन दे सी इट हियर एज वेल? यहाँ तो अन्य को भी नजर आ रहा है। कैन दे अप्रिशिएट इट हियर ऑन दिस इमेज?
बड़ा लाइट सा है।
हाँ, यही कहना चाह रहा हूँ कि कई दफा इट ऑल डिपेंड्स कि आप कहाँ भेजते हैं। एमआरआई 1901 का है या 2021 का है। सो ये अगर होगा तो नो प्रॉब्लम, बट दे मस्ट अंडरस्टैंड कि इस तरह की पिक्चर भी आती है, यू नो, वेरी लाइट, बट इट्स नॉट ब्लैक। आगे ये लेटरल साइड का, अब ये लेटरल की वो चीज देख रहे होंगे जो मैंने कही थी। ठीक है जी, मैंने बस इतना बताना था। I kept it very simple. I brought 3 types के medial, lateral और ये bucket handle tear. लेकिन मैं ये सिर्फ ये बताना चाहता हूँ how to differentiate a normal with an abnormal. अगर आप सिर्फ 2 दिन 30 minutes spend करें, what you call it, ये केडी ट्यूबें होती हैं, YouTube, मसूद उमर वाली नहीं, I'm talking about scans, MRI scan, YouTube, and then I swear you okay यार बस इतना easy है. I'm talking about basics, tear का. I'm not talking about ACL, PCL और जो बहुत सारी MRI नहीं का है, no, but you must know. और थोड़ा सा मैं दोबारा बता दूं, हर चीज 2 होती हैं. 2 ligaments अगर आप याद रखें, quadriceps tendons and patellar tendon. Then you go on the side. You should know how to look for MCL, medial collateral ligament and lateral collateral ligament, and then ये जो iliotibial band, ये भी थोड़ा सा पता लग जाए. And then मैं सिर्फ meniscus को आपको आज डिस्कस कर रहा हूँ. ये बार फोटोज देखें घर जाके, बार नॉर्मल एबनॉर्मल. ठीक है जी. शेख रशीद की तरह 3 क्वेश्चन. आई एम डन.
अच्छा जी, थैंक यू शम्स भाई. ये आपके साथ 3 ऑनलाइन क्वेश्चन भी आए हैं. एक्चुअली मैं ऑनलाइन भी हो गया, बड़ी उसमें ज्यादा क्लियर पिक्चर नजर आ रही है मोबाइल में, और शम्स साहब भी बहुत क्लियर नजर आ रहे हैं. तो जो है ना, हम अभी क्वेश्चंस को स्किप करते हैं और लेते हैं, क्योंकि डॉक्टर आमिर ने जाना है उनकी इमरजेंसी.
बिल्कुल. आई वुड लव के कोई सवाल पूछे ना मुझसे.
नहीं, अभी आप रुक जाएं, और आपने नहीं जाना, डॉक्टर आमिर ने जाना है, तो उनको अभी ले लेते हैं लाइन पे. डॉक्टर आमिर, over to Dr. Amir. He will talk about repair versus resection, indications and contraindications. And if he gets the time, he will show us a couple of videos of doing a correct Mcmurray test also. That's what I requested just now. So over to you, Dr. Amir.
Assalamu alaikum, and thank you very much once again for inviting me to talk. I'm sorry, I'm going to have to rush just a bit because I'm on call today as well. Can you see my screen?
Yeah,
that's right.
Excellent. And if there are any important questions, just stop me. It's better to do just what we can do, even if it's a little bit, but do it well, I think. So feel free to stop me. So these are the type of tears we've already gone through, and hearing the talks before in your auditorium, you've got people who are extremely vastly experienced, and they can get you and explain this a bit even more better than I can. But here's a bucket handle tear. So you can see it's come away from the rim and it's joined like this. You can see how the condyle can sit just in that gap there. There's a complex tears, radial tear. We've been through this already. Now, I firmly believe that a meniscal repair is an essential technical skill. And if you can't repair a meniscus, my feeling is that you should not be doing the arthroscopy. Not everyone needs to be able to do everything, and it's great to know Pakistan is becoming more and more specialized. Not every meniscus can be repaired, and I think the skill is to see which meniscus can be repaired, which can't be repaired. If you can't repair the meniscus, you've got to think, can I keep this meniscus in? So should you be scoping something that's non-repairable? Very occasionally you do because of locking, mechanical symptoms, but I'm sure you're going to talk about that for the rest in the rest of the conference. Now, what revolutionized my life is learning how to do pie crusting of the MCL. And I think that is the one thing that gives you the ability to actually repair menisci. Or actually, even if you are going to do a partial meniscectomy, unless you do a pie crusting, you can't see exactly what you can actually retain. And sometimes I'll do a bit of a combination. So the very, very frayed edge, you can just resect back and then repair what's behind. There are newer devices on the market. I've just been shown a device this Monday, and I've got a picture of it that's making our lives much easier. They're expensive, but inshallah, they'll come to Pakistan soon. We need to look for rampant meniscal root lesions, mainly because at the moment, although things are changing, the radiologists don't necessarily look for them, and not all MRI scans are of the quality that will show up a ramp tear and a meniscal root tear. So when we do an arthroscopy, should look for them, and I've got a diagram for those. Speakers have already alluded to this before. I think we need to go away from red on white, white on white, red on red tears. Overall, my failure rate of meniscal tears is 4%. So 96% of my patients heal, and I repair in any zone. If it can take a stitch, I'll repair it. Now, there are other things that you can do as adjuvant, and this is now in the literature that you can repair isolated white on white avascular meniscal tears, and you can get a good functional repair result. There's a question already about if you do a meniscectomy, how quickly will osteoarthritis develop? Well, actually quite quickly, and there is a direct link between taking out the meniscus and developing degenerative change earlier than normal. Now, the lateral meniscus is more important than the medial meniscus. And thankfully, because of the reasons that were explained before, it's the one that's least likely to be injured because it's more mobile. So the lateral meniscus is incredibly important to preserve. Meniscal root tears, again, if you have a meniscal root tear and you leave it, the degeneration is pretty rapid and the knee does fall away very quickly. So here's a slide just to see, we'll show you once again. This is a summary paper, but if you look at this, papers in 2000 and 2010, so 10 years apart, big follow-ups, 13-year follow-up, 9-year follow-up. If the meniscectomy is M, repair is 4. So functional scores are relatively similar. But for meniscectomy in 2000, 13-year, 27% went on to develop degenerative changes within the follow-up, whereas only 4% of those people who had a repair. In 2010, look, if you do a meniscectomy, 60% have gone on to develop osteoarthritis. If you repair it, 20%. So I would argue, yes, we do need to repair the meniscus. But having said that, I won't scope anyone or unless I really have to, where I don't think I can repair the meniscus. And this goes back to what Shams was saying. that we need to be able to read the MRI scan, and then you need to say, am I going to be able to repair it or not? If the answer is no, then you really try and convince the patient that over time, this may settle. If functionally they are locking, they are giving way, and they've got a sort of job that they need their knee symptoms to go away quickly, then you can say, right, I'll take your meniscus out, but you will have degenerative changes earlier, and you may have more increased pain because of the increased pressure in the knee. So if you have a degenerative knee and you do a partial medial meniscectomy, you saw that really eloquent diagram with the arrows and the pressure area. So you'll reduce the area that the pressure will go over, and so the pain will increase. So going through pie crusting, again, Shams has seen this video, and what that does is open up your joint space. So here's the anatomy. So the medial epicondyle, medial tibial plateau, and it's more posterior than you think it will be. And so what I do is I look inside the knee, you almost see the fibers of the MCL, and then you pie crust it from the outside. And this is a video. It's not my video, but it's the best video that I could see actually online. And you could see that lifting up. Did you see the femoral condyle lifting up? Yes. And you titrate it. So as you put a valgus force and you slowly lift it, it will lift up, but don't get too excited. And if it does, if the MCL does go pop, don't worry, just put it in a brace for 2 weeks. Otherwise, you don't even need to brace them. But you can see now you have good, nice access. So I do have a video of mine, which I'll show later. There's no need to be worried about doing a pie crusting. There are plenty of papers showing that there's no problem. If you pie crust, there's no long-term problem. Controlled release is absolutely fine. It's a safe procedure. And in fact, it gives you more space. So you scratch them condyles much less, and you can repair much better. Meniscal root tears. Leprade in particular has been absolutely instrumental in defining how important meniscal root tears are. You'll have reparable degeneration, and according to Leprade, if you have a meniscal root tear, you will almost, or if you have osteonecrosis of your femoral condyle, almost always you'll have a root tear. So he says meniscal root tear is pathognomonic of osteonecrosis in the knee. So these are ones not to ignore, and it's the only tear that I will ask the patient to seriously consider, let me repair, even if they have some early degenerative change and they're in, say, their 50s, I will still try and repair their root. And this is, again, you can, this is more towards the root and the ramp. You could, the femoral condyle is, if you can imagine this as a shape of a tire, here, even airplane here, here's the meniscus. The root, if this root, this whole thing is come off the base and slides, then this will slide forward and backwards. The ramp is when this, the meniscus comes away from the capsule. Again, you can see there will be no stability provided by the meniscus. So again, the femur can move forwards and backwards. So that's why you get instability. One of our physiotherapists was skiing in Switzerland, and she ruptured her ACL, and it was repaired, reconstructed in Switzerland. So she came back and she had ongoing instability. I repeated her MRI scan. The only thing that was a problem was the ramp. So I went in, all I did was repair the ramp, and she's completely stable now. She's back to her high level activities. So the ACL was reconstructed absolutely brilliantly, but the one thing they missed was the ramp tear. So we must always look for a ramp tear when you scope, and especially if there's an ACL. There's a whole classification on root tears, and I'm going to just skip over the classification because this is something that you can get just because I'm sorry about lack of time for me. But you could see where the root tear will be. And if you go back to this picture of stability, you can see if this is all detached, then that stability is gone. And Professor Omar mentioned and asked you about hoop stresses. So they're the stresses that will go from the back to the front to dissipate load. As soon as you've got a root tear, you will see there's nowhere for those stress to dissipate because there's no direct connection down into bone. So that is another reason why this is, if we don't do this quickly, this is almost the angina before the heart attack for the knee. So be careful for root tears. Now, when you do, there are radiological signs, and Shams has already gone through them, and I'm sure you'll have lots of questions about them. But there are some signs particularly for the root. So the absence of a normal meniscus, a radial tear at the meniscal root, and then there's also the truncation as well. You can see all three signs across here. Now, we saw this the MRI, the meniscal extrusion. When you have a meniscus that's extruded so much, always think about meniscal root tear, because it's one of the signs that's over 2 millimeters. So this is 3.4 millimeters. So over 2 millimeters, you've got to think about a root lesion. Now, how do you repair it? Well, you've got to drill a tunnel. And this is the area, like we saw in the anatomy lecture, where you have the skirt, as it was described, at this periphery, but actually bony attachments at the horns. So you've got to draw this in, you have to drill a socket. So 5-6 millimeter socket, bring the meniscus into that socket, you put sutures into the horn and put them in a tunnel. Now you can do 2 tunnels, 1 tunnel over a button, over an anchor. Although there has been good literature showing that no matter how tight your anchor is, if you do a root with an anchor, you will lose some tension, so the root will become a bit loose. So over a button is better than an anchor. Just be a bit careful, especially when doing these on females, because they have that fat in between the bone and anything else you want to get to. You have to make sure that that button is lying on the bone. So the one thing that you can do is with these buttons that have these 4 holes, you can put a sliding suture through 2 of these holes. So you do your sliding the knot down onto the button so it sits really well onto the bone. You get your assistant to pull down on these meniscal root sutures, and then you can tie it over. So that's a little trick that you can do to make sure this button sits on the bone and there's no fat behind it. Be careful when you do your ACL tunnels that you don't impede into the ACL tunnels. Some people, even if there is a meniscal root, will use the same tunnel for the meniscal root, but I've never got that to work because I do anatomic ACLs and my tunnels are always slightly different. So I use a button and secondary fixation with anchor. So the ramp lesion, as you can see here, there's a medial meniscus, there's your posterior capsule, and the medial meniscus comes away from the capsule. There it is. And then all I can ask you again to think back to that picture I had with the tire and the ramp stabilizing that wheel. So if you imagine the curve of the femur and this is all now floppy, the whole femur will go backwards and forwards. It would slide when you rotate as well, and that's what gives you the instability. You do have to really know how to scope and create a more posterior tunnel. You can use all sorts of things like first pass and everything, whatever you're going to use. What you have to do is pick up the posterior capsule or the meniscus, whichever, and bring the two together and ensure that your stitches are from the capsule into the meniscus. So, and that's a difficult bit. So you need to get your grasper. So often what I'll do, I'll make my posterior medial portal. I get a grasper, grasp that capsule, bring it to the meniscus, or depending on how it is, you want to grasp the meniscus, but bring it to the capsule. And then your first stitch is the most important one. As soon as you put that first stitch in, you tighten it, it comes together, and then you can just put your rest of your stitches in. You can do this with fast fixes, and again, it's been well documented in the literature that you can do it with a normal fast fix if the other instruments are too expensive. But you have to, in my opinion, you have to make this posterior portal and have a direct access to the capsule to bring that capsule forward. And I'm sorry that I can't be in the workshop with you guys, because that's something that I will, inshallah, show you when we finally get to meet again and things change in the world. So I'm going to show you a video now, and this is of one of my patients who's given me permission, and I'm just going to go through the thinking of how I think about menisci and when to repair. And look at this gap. I've already opened this up, so you could see how much room I have to actually see. This is the meniscus, or the shock absorber, and you can see the tear just here. And it's just a ragged tear here that's then allowing this meniscus to come forward and get caught. Mr. Malani, the rest of your cartilage is actually looking quite good. If I took this out, the worry is that you'll rapidly get wear and tear. So I'm going to actually attempt to repair this with sutures rather than take all this meniscus out. There is the chance that the repair may fail, but one thing, Shams asked you guys, which is the most difficult or most commonly missed tear? I would say probably one of the most commonly missed tears is the undersurface tear, because a horizontal tear you'll see in the next video, but the undersurface tear can then just become a full thickness tear. So when you do assess menisci and something is shown, take your hook, pop it underneath and lift up and look underneath the meniscus. Because if you see a tear on the inferior surface of the meniscus, it could be a stitch in time, says 9, and I will just put a stitch across it. Okay, your young age and the fact that the rest of the cartilage is more or less pristine here, I think we should give this a chance. I'm just using a needle here just to promote blood supply, and so it heals better for you. And again, this needle is just to promote blood supply, so it heals. So Mr. Malani, now this is a probe again, and I'm really trying to pull this forward, and it's nice and stable. And I think that's much better than having taken away all this meniscus and leaving this uncovered. So hopefully this will now repair, and you won't be symptomatic anymore. It does mean that you've got to be careful over the next 4 weeks. But as I said, because the cartilage is so good, I think this is the correct thing to have done. I hope you'll agree that if we had to do a meniscectomy, I would have had to take all that meniscus out, The rest of the cartilage is fine, so that's why I just left things here. Here's a lateral meniscus, all looking good. Now, the one thing that I also do is I'll do a microfracture in the notch because that releases stem cells to help with healing. So that's the other thing that you could do to do biological repair. There are people who will inject PRP, make a clot, and stitch a clot to the repair. All these things are described. Now, this is now a bucket handle tear. So you can see how the bucket handle, as was described before, has come and now encompassed the femoral condyle. So does that make it, can you see the bucket handle?
Yes, we can.
Okay, so I don't know whether, did you see that from the beginning?
Yes, sir.
You can see them.
Right, so this is, let me just see this, I could talk again. So there was just some confusion. And then just over here, this is why you get the double PCL sign. Can you see this is in the notch? This is the bucket handle going into the notch. So if you are going to get an MRI scan, like Shem said, someone lying down, this meniscus is what you're seeing in the MRI scan. And behind this, you're seeing the PCL. Let me go back, sorry. So there you could see that would be the PCL at the back there. So hopefully now you'll see why the MRI looks as it is. Now, also in this one, you'll see in this in a little while is a horizontal tear, which is why I chose this video. It will come in a little while. There you go. So there you go. Here you could see that meniscus going in to the notch. Now, if you imagine an MRI scan, you'll see the PCL and you see that meniscus in the notch. So someone asked on the questions, explain the double PCL sign. So that's the explanation of your double PCL sign. So the next thing will be to reduce the here now is the horizontal tear at the back. So you can see this, just like Masood said, when you slice some bread, you can see it. So there is a horizontal tear. So in this meniscus of a 17-year-old, not only is there quite a significant bucket handle, but there's also a horizontal tear. So overall, quite a complex tear. Now, this is some years ago. So how I'd repair this is different. But again, just promoting the blood supply. And the first thing to do would be to actually close down the horizontal tear. Now, at the time I did this, I didn't have the newest stitch, which will show available. So this, I just had fast fix available. And this is how the meniscus would attach back. You can see I've opened up, I've done my pie crusting now. You can see how much space I have compared to before. This is what I do every time. I look for a ramp tear and a root tear. Here's the capsule, here's the meniscus. If that pulled away, this is where I'd put the stitches. How you do it, we'll talk on a workshop one day, but I'll put a portal and bring this fold or the meniscus to the fold and put a stitch across. So that's carefully looking for a ramp. This is now looking for a root. So sometimes to get there, you just have to shave that bit of the condyle off. It's non-articulate, it's in the notch. So sometimes to put your camera in there, you will need to just take a little bit out there, but that's perfectly acceptable. So this is putting sutures in the horizontal component first to close that down. Because there's no point stitching the bucket handle to the back when there's a horizontal tear because everything will just fail. And now slowly stitching the bucket handle back to the remnant. And you can see how you can pull it across. Well, I'll just speed this up just for the sake of time. And this is just clearing up. Now, yes, at this point, this doesn't look pretty, but you've got to, this is a 17-year-old. It's a biological thing. These cells will grow. And actually, we do have an MRI of him. This is about 2 years ago now. He's a nephew of my anaesthetist, and his MRI actually is looking very pleasing. And inshallah, when we talk again, we'll go through the MRI scans before and after. So that is that. So my practice, I have all of these things available for when I do an arthroscopy and a repair. Now, I'm very fortunate. I live in a system where all of these are on the shelf. I'll just say, can you give me the Nova Stitch? And there will be the Nova Stitch. There's a root repair system. And I know you don't have access to a lot of these things, and they're very expensive. However, all these things do is make life easier. There are lots of ways you can do this. You can use cannulae, simple, cheap cannula to repair them. The back ones are tricky, but you've got fixed tubes and needles, and you can do inside-out repairs where you make little mini incisions. And again, inshallah, you will see that in the workshop. So yes, I have lots of tools. It makes my life easier. So what would normally maybe take an hour doing by hand takes 5 minutes because of the instruments, but the principles are the same. This intrameniscal stitch is a game changer. And what it does, all the rest of the techniques rely on you putting something into the meniscus and squashing it to the capsule. But with this, you can actually repair within the, this is what I'm saying. So with this newer device, you can see that you could put a stitch in between the meniscus itself and not have to go into the capsule. And this is how you can then repair a radial tear. So you could go side to side or horizontal tears. And again, this diagram I put mainly for demonstrating the different types of tear. And then with the cleavage tear, I said I'll do things differently now, because now I just put this, what's called a hay bale stitch, because you can just wrap things round. And it tends to look better and it flattens out better. Portal placements, you need to be able to be comfortable switching from one portal to the other portal to get the best access, because you can't access the whole meniscus just through one portal. So you will need to switch, you need to be lower, you need to learn where to put the portals. And I promise you the newer thing that's come out, I always like to keep you guys up to date. This hasn't been, I think there have been 2 stitches that have come into the UK just now. Oh, this is a slide after. Angle of approach. So what I do is use a spinal needle. So if you put your spinal needle through the capsule, what you can do is you could see if you put your portal there, would you be able to reach it comfortably? So that's too high, that's too low. Where it's absolutely perfect, you then make your portal there. If you've already made your portal and it's not in a great place, have no problems with making another portal. Make as many portals as you want to get you the ability to repair the meniscus. So they just showed me this on Monday in a cadaveric session. This is the new Fast Fix Flex. There's only 2 of these, I think, in the country here in the UK yet. I think they've only used it a couple of times clinically in the USA. But what we can do now is bend this Vasflix, and in one version of this, you can even bend the tip. So you can get right to the front. So repairing meniscus has become even easier. So in conclusion, please, please, please save the meniscus. Look for ramp and root lesions. It's technically demanding. You need lots of little shortcuts. You need a good MRI. We often get 3 Tesla MRIs and an expert radiologist. It's specialized surgery. So if you're not comfortable repairing, you got to think, should you really be doing the arthroscopy? It's expensive, and that's the biggest drawback. Is expensive if you use all the tools, and I fully appreciate that. I live in a very in an environment which is very different to that in Pakistan, but there are cheaper techniques you can learn which are more laborious. But yes, being privileged, we can have our tools. Thank you very much.
Thank you, Dr. Amir. Very exciting, challenging things that you're doing, indeed, and a lot of learning for me also, especially this new compressive repair, sorry. And your challenge has always been how to repair a radial tear and a horizontal tear. So, thank you very much for a very illuminating talk.
One other thing, sorry, Masood, you asked me about Mcmurray's test, and I must say, I never do Mcmurray's test.
I was going to say the same.
I do Thessalys Test, Thessalys, Thessalys Test. So imagine it's the left leg. So what you ask them to do is lift the right leg off the floor. You ask them to flex the left knee by about 20 to 30 degrees. So what you do is you put your hands out and you say, put your hands on my hands so you can help stabilize them. They bend at 20 to 30 degrees and you ask them to twist side to side. So essentially you are doing a Mcmurray's, but with their body weight, and they will say, when they twist, they say, I can't do that anymore. So Thessalys, Thessalys, Thessalys Test is the test that I do. But any provocative test is okay.
Let me confirm by demonstration, Dr. Yunus. So can you see my resident, Dr. Yunus, very energetic person?
Yes.
So he has problem in the left knee, for example.
So could you turn to your left by 90 degrees? Excellent. Now, Professor Umar, could you stand right in front of him?
Yes. Stand up.
And if you could hold, someone could hold his microphone. Professor Umar's microphone, take the microphone. Now, Professor, if you could put your hands facing the ceiling, or like that, that's fine. So, sorry, I didn't know your trainee's name again. I've forgotten his name. I didn't hear. Zakir?
Yunus.
Yunus. Dr. Yunus, can you lift your right leg up? Now, can you bend your left knee by 20 degrees? Just slightly bend your knee. Now, can you rotate side to side? Yes, perfect. As he rotates to the medial or lateral side, there'll be pain. You can see it's a standing up Mcmurray's.
Yeah,
it's called
thank you, Dr. Ahmed.
Can I, before you go, I have 2 things to say. Amir, thank you very much. I must say, you know, the under surface tear, that's what I wanted to say. But Professor Masood Umar and His Royal Highness Chairman Saab, they said horizontal tear and I just ignored it. it is under surface. I do apologize, number one. Number two, once again, can I tell the guys, I assisted first arthroscopy of my life in 1989. And thanks to Amir and due to these and Masood Umar, these workshops, I learned after, good Lord, 30 years about pike thrusting. And it has changed my practice. I've been doing it donkey years, and I didn't know just a simple thing, to put a needle and in MCL and all that. So these meetings, they are very beneficial, and I'm very thankful to Amir. And inshallah, one day I will share 5 or 10% of my practice with money-wise with Amir. Anyway, thank you, Amir.
I look forward to that. I can retire then. May I please beg my leave? I have to be in the hospital very soon. So I'm very grateful for your kind comments and for inviting me. Professor Masood, am I allowed to leave?
Yes, please. Sorry for having kept you over time. And thank you for your contribution. You've always been very approachable, and I think people must have enjoyed your talk and videos. Very conceptual talk. Thank you very much.
I'm very grateful. Any questions, please email me. Thank you. Thank you very much. Assalamu alaikum.
Walaikum salam. Shamsa?
मैं 2-3 क्वेश्चंस जो आमिर से पूछने थे, मतलब इन कंटिन्यूटी और जो मुझे वो किए हुए हैं, ये जो कोर्सेज हैं या वर्कशॉप हैं, these are the levels which I couldn't make out, is it a basic or is it advanced. लेकिन चूंकि meniscal repair के बारे में है, तो जो definition of different meniscal tears थी, या वो MRI पे मैंने बताना मुनासिब नहीं समझा. I thought it is best for you to know what is a tear and how to see it. ठीक है जी, उसमें एक एक्सट्रूशन आ गई, बकेट हैंडल टीयर आ गया, एंड नॉर्मल जो है मेनिस्कस. बाकी ये वर्टिकल, रेडियल एंड ऑल दैट, विद द पैसेज ऑफ टाइम, once you start learning or once you start to know कि जी ये टीयर है, then I'm sure you will go into the details.
अच्छा शम्स भाई, ये आपकी टॉक के दौरान 3 ऑनलाइन सवाल भी आए थे, वो मैं बारी बारी लेके चलता हूँ आपको ना.
प्लीज.
एक पहला सवाल था डॉक्टर अजीम है कोई, उन्होंने सवाल किया, कैन यू रिपीट डबल पीसीएल. देखिए तो आमिर ने भी दोबारा समझा दिया कंसेप्ट डबल पीसीएल का, तो मेरा ख्याल ये अब समझ आ जाना चाहिए डबल पीसीएल साइन. ठीक है ना, इसको आगे चलते हैं. काइंडली टेल अस अबाउट ग्रेडिंग ऑन एमआरआई. डॉक्टर शम्स,
आई थिंक ये मैं बार बार यही कहना चाह रहा हूँ कि ये जो ग्रेडिंग वगैरह है, आई थिंक वी शुड, अभी मैंने नहीं किया, प्रिपेयर नहीं किया, मेरे पास एक और है लॉन्ग लेक्चर. आई थिंक मैं जो कहना चाह रहा था कि बेसिक्स हमें आनी चाहिए. यू अंडरस्टैंड कि हाउ टू रीड, हाउ टू सी दिस टीयर, हाउ टू सी दिस टीयर, and that's all. If you know this, this is more than enough for an orthopedic surgeon at this level. Once you go into a excuse me, slightly higher level where you start repairing it, then you must know the grading. The many dasni grading on. Next question.
जो नेक्स्ट क्वेश्चन था वो ये है कि हाउ टू डिफरेंशिएट बिटवीन लॉन्गिट्यूडनल एंड रेडियल टियर. आई थिंक उस पे भी हमने काफी बात कर ली आफ्टर योर टॉक. They are at right angles to each other, and the concept of sagittal versus coronal orientation वो भी हमने कर ली थी. So ये बताएं कि क्लिनिकली प्रैक्टिकली आपकी प्रैक्टिस में जब ग्रेड 2 एमआरआई रिपोर्ट होता है तो व्हाट इज योर ट्रीटमेंट प्लान.
मैं थोड़ा सा, मेरा अब जब से आमिर के लेक्चर शुरू हुए हैं मैं परेशान हो गया हूँ. मेरी प्रैक्टिस से तकरीबन खत्म हो जानी है, तो मतलब अगर मैंने रिपेयर का जो मसला मेरे पास आता है 40-year-old with grade 2 और grade 3, मैं क्या करूंगा? ठीक है जी, 40 is such a age कि उसमें age is not a limit these days. Am I gonna repair it? I'm gonna leave it. I'm gonna do a partial. वो जो मेरी practice bread and butter है. So it's very difficult. But saying all that, can I just say one thing, Masood? I personally believe if the patient is symptomatic, if you listen to him, if you know that if he has locking or all the, or if it's affecting his life, जैसे वो आमिर ने भी कहा, then you go into the science जो भी आपके हैं, and then confirmation. I rely, mainly on history, and then I'll offer him. Yeah, but I'll definitely will go for scope.
Achha. So let's go around with the faculty. My question is, again, I'll repeat, the young man, footballer who has had a recent injury, he is symptomatic clinically, he has signs, he has symptoms of a meniscal injury, right? And you do MRI and we find that he has a grade 2 medial meniscal injury, posterior hand. So let's go around, Dr. Kazim, what is your treatment plan for him?
So the scenario is football player athlete, and of course we love to play football and regular doing a lot of sports activity. And he's saying he's having a light injury, and because of that injury, the reason he came to me is basically the pain in the knee joint. So right. We all have to understand one thing, why the meniscus doesn't heal, why we need to repair a meniscus. That's a basic question that always we have to ask ourselves and we have to understand. The reason that meniscus doesn't heal because of the synovial fluid. The synovial fluid contains a hydrolase enzyme, which doesn't allow the fibrinogen to be converted into fibrin because it's going to degrade it. So what we do, we want to create an environment between the tear so that's become close to each other at the end of the day. And because of the blood supply, there's no synovial fluid enter between that tear because of the closure to each other, and that lead to the healing. You all know in the body, everything had to heal. And why we try what we do, we repair it, stitch it so that healing can take place. That's what we understand with the primary and secondary. So first of all, grade 2 that Dr. Masuma told me, we have to first of all counsel him. If this is a grade 2, it's big enough, it doesn't extend it to the you can say capsular or synovial meniscus level. There will be a lesser space. You have to decrease all your sports activities. You have to have some rest and give it a chance for 4 to 6 weeks and see how the things happen. But if the patient understand that and he is willing to give it a nature to heal it, because of the grade 1 and grade 2, we can manage it conservatively because the tear is not aparted to each other. There is a chance. But if he doesn't think he can't wait, we have to scope it and we have to repair it. But at the grade 1 and grade 2, first I will going to give him a chance. I will let the nature see how it's going to take it. And later on, if it doesn't going to heal, then of course the earth is going to plan for arthroscopy.
Okay. Khaled sir, your opinion, sir?
My decision to operate would depend on patient's complaint and symptoms. The MRI report, as far as you said, grade 2 is not a complete tear, and Kazim is right. If that is the case, wait and see would be the attitude. But if the patient is complaining, there could be some other reason for the pain also. So I would still go for arthroscopy if the symptoms are there.
Excellent. I totally agree.
Irfan Sahab?
ਸਾਡੀਆਂ ਸਕੋਪਾਂ ਬੰਦ ਕਰਾਉ ਨਾ
If only the symptom due to meniscal tear and grade 2, I think go to arthroscopy, do arthroscopy. And most of the time, the radiologist is saying grade 2, and in arthroscopy, we found grade 3 and grade 4. So the patient, it depends the history and examination. If patient having complained for last 6 months, for 3 months, instead of the physiotherapy failed, conservative management failed, then I think arthroscopically it is grade 3 and 4, we repair it.
So I think the grading is obviously radiological diagnosis 1, 2, 3. So grade 2 by definition is not reaching to the surface. So you won't be considering resection. क्या set करेंगे आप सब नहीं रहा. Either you won't be considering repair. It's not visible here. So I do not consider arthroscopy where MR is reporting grade 2. Obviously symptoms are important. Symptoms treat तो करने हैं हमने. Duration is important. If the patients come a duration 3 months, 6 months, relatively longer duration, conservative already try कर चुके हैं, and your clinical findings are very much pointing towards the meniscus tear and the grade 2, then or reported grade 2 है, then obviously counseling is important. Then you might be looking something at MRI not 100%, 95% के sensitivity है. You might be missing a ramp lesion जो report नहीं होता. You might be missing some. It might be reaching to the surface जो कि कभी report नहीं हुआ MRI में. MRI patient हो सकता है 6 महीने पुराना लेके आया हो, तो ये सब चीजें भी देखनी पड़ती हैं. So per se, I may not go for arthroscopy in a grade 2 lesion. And अभी तक counseling की है patients की कि okay symptom नहीं होते ठीक, तो we will do a diagnosis scope and see if it is a grade 3 will repair it. लेकिन मेरे ख्याल में अभी तक जरूरत नहीं पड़ी है. They do get well with conservative management most of the time.
Same for myself, I would, if they are too symptomatic, sometimes try a steroid injection also with Marcaine. And very recently, I gave you an example, just 2 weeks ago, I did a very young man. He had, it was very symptomatic. And we did an MRI, it was grade 2 tear. So I said, just hold on to your physical activity, as Khan Saab said, but he, over 2-3 weeks, he was very symptomatic. So I said, we can inject short of an arthroscopy. Here, cost is also an issue at our setup. Arthroscopy, simple diagnostic meniscectomy would reach up to 200,000 rupees. And that's a major chunk out of a young man's job. So I injected him and he still would not respond. After 3-4 weeks of injection and icing and resting, he still would not respond. And then he was convinced that, and I was also convinced that he needs a scope. So when we scoped him, I just found abraded anterior horn lateral meniscus, right? So it was not, it was still grade 2, the abrasion was not, the tear were on the surface and they were not going through and through. So I just abraded the tears and I couldn't do much. As mentioned, examined the knee thoroughly for any posterior missed tears, for any other injuries, and then come out. Hence I raised this question for faculty discussion. I think all of us get.
Can I, Masood, share one thing more? I say.
Question only for operating surgeon, sir. आपने कहा आप ऑपरेट नहीं करते.
नहीं मैं कहा मैं ऑपरेट ही सिर्फ करता. सुनते नहीं मेरी प्रैक्टिस खराब कराऊं है. Anyway, guys, one thing you must understand. We don't treat X-rays or MRI scans. We treat the patient. ये मैसेज दूसरा लेके जाएं घर पे. We don't treat X-rays, we don't treat MRIs, we don't treat reports. We treat the patient. If the patient is symptomatic, in your back mind, you should have one the top notch, the first priority is always conservative. जैसे वो मेरे कोलीग ने कहा कि ये घूम फिर के आए होते हैं आपके पास, तो वो कंजर्वेटिव मैनेजमेंट अक्सर हो चुकी होती है. एंड देन यू से प्यार मोहब्बत से कि नहीं तू 2-4 हफ्ते और रेस्ट, तो वो फिर खालिद शाह के पास जाएगा और वो 15 मिनट के बाद स्कोप कर देगा. The question is that you must understand it is the ये जितने भी टेस्ट हैं, they are there to help you, not to ये जो है ना कि we don't treat MRI scans whether grade 2 or grade 4. If the patient is asymptomatic and he has got a grade 4 tear, आप ऑपरेट करोगे, वो तनु कुटेगा फाड़ के. You understand? So you must operate और या जो भी है, treat the patient, not the ये क्या होती है investigations.
Point taken, sir. Point taken. एक सवाल और है डॉक्टर वैस मेमन का ऑनलाइन. Sir, what is pie crust and what is the indication? लेकिन pie crusting जो डॉक्टर आमिर ने समझाई है काफी reasonable तरीके से डिटेल कि when you are doing meniscectomy posterior on medial meniscus, lot of young patients knees are very tight. Despite a valgus knee support, you are giving valgus, external rotation, the knee is not opening up, and you cannot, your scope cannot enter the posterior on, or it is not clearly visible. So I have tried it, especially as Shamsa was saying, it was in this one, in one of these workshops, I also learned pie crusting by Dr. Amir, who demonstrated that. And take a spinal needle and you pie crust the MCL. It is posterior, as he said, rather than middle or anterior. And just make multiple jabs with the 18 gauge needle. And that kind of gives you a relative more flexibility of the MCL, hence you can enter the posterior compartment much better with a scope and with your instrument to dissect or repair whatever is the indication. So pie crusting is a very good technique. Obviously, it has a learning curve, but very valuable in tight knees where medial posterior horn medial meniscus is difficult to visualize, and you want to have a better look there or do some procedure there.
I think, Masood, if we make it a routine to do pie crusting, your life will be much, much better. Routine.
जिनका पहले ढीला हो उनको भी.
I'll say nothing.
वैसे कितने जैब्स आपको करने पड़ते हैं?
The question is how many jabs to do for the MCL. I think 4 or 5 in my practice. And if you take a needle, if you think you're entering into MCL or आप अंदर से scope से भी देख रहे होते, you can use the sharp edge of the needle to have a greater cut even with a single jab. So that is enough.
Side पे हो जाए.
That once or twice you can hear a pop also. That you have a major thing in the MCL, and that is also clinically not very significant. You brace them for a couple of weeks and they are okay. So
Shaji,
to answer the question.
if you put the spinal needle in, if you are in a position, और पहले ही उसमें जैसे मसूद ने कहा पॉप की हो, और you will see the difference कि वो जो है ना थोड़ी सी स्पेस खुल जाती है. If you are happy with that, stop it there with 1 even. लेकिन यह है कि he's right, 2-3 शुरू में 4 करनी पड़ेंगी. मसूद उमर ने पहली दफा 9 की थी. But anyway, so it takes लेकिन if you do it correctly, properly, in the right place, and if you see the gap कि तुम्हें इतने की जरूरत है, इतने गैप की, you don't need to go further than that. But there is a learning curve of 5 minutes.
जी अच्छा जी, सवाल आप पार्टिसिपेंट्स ने सवाल लिखे काफी देर, फैकल्टी आपस में गपशप कर. Harun Kasi from Quetta. हाँ, उन्होंने शुरू में जैसे the question is just for online participants कि Dr. Amir showed trephination in the white zone, and he said I would also repair white zone. He doesn't consider white zone as non-biological. So that's what he said. Yes, I agree. And I think it will take us some time to digest that. The traditional learning has been why doesn't heal, but now all inside has made it so easy, and the results have proven that long-term degeneration can be prevented even if you preserve every bit of meniscus. And every bit of meniscus has a function, even if it is in the central zone, white zone.
As in the second talk after Khalisha, Irfan said they discourage now to use these terms.
Discourage,
white,
exactly.
white, red. So
whatever is repairable.
Yeah. That's how the evolution and changes come. If you keep on staying in the routine status quo, things don't get improved. Now look at this. They have mentioned that 8 years and 10 years results, and they are encouraging, and we must adopt it.
Dr. Zai Daskar is also online. Any comments so far, Dr. Zai? He is a very eminent arthroscopic surgeon in north of Pakistan.
I shouldn't be saying anything, but Zahid Askar, wake up.
Shamsab, can you kindly please privately call him to come online? We need to listen to his views. Thank you.
Okay.
Okay, any other questions? सब लोगों को TS समझ आ गई, TS morphology समझना इस वर्कशॉप का बेसिक, राइट? अगर morphology नहीं समझ आएगी तो हम ट्रीटमेंट प्लान नहीं बना सकते। रेडियोलॉजी पे समझनी है, पहले क्लिनिकली समझनी है, दिमाग में बिठा के मेनिस्कस की 3D ओरिएंटेशन खालिद साहब ने बताई, खान साहब ने आपको TS बताया किस तरह एक्सटेंड हो, उससे फिर ट्रीटमेंट प्लान गेज होगा। अभी हम टेक्निक पे जाएंगे, इंडिविजुअल टॉक्स में ओवरऑल तो डॉक्टर आमिर ने कवर। Any questions so far? जी सर।
पीडियाट्रिक एज ग्रुप में हमें बहुत कम नजर आया कि पीडियाट्रिक एज ग्रुप में लेस देन 12 इयर्स काफी कम पेशेंट आए या रिपोर्ट नहीं हुए, उसमें हम इस तरह डायग्नोस करेंगे और क्लिनिकल सिम्टम्स क्या होंगे उसके?
In pediatric age group, the meniscus is very vascular and repair is very rare. Second, in pediatric age group, elasticity is more in meniscus is compared to adult and more elderly. So meniscal tear incidence very low in pediatric age is compared to younger and adult. इसी वजह से हमारे पास कमी आती है। लेकिन द ट्रीटमेंट प्लान क्या आपका मेनिस्कल टेयर कितना है, ग्रेडिंग को क्या है, और उसी के मुताबिक always in children repair.
Mostly Dr. Irfan ने सही कहा, not very young children, but जिस time adolescent हैं, after 12 teenage में they do come with sports injuries and there's a chance that it all होगा. And usually दूसरा जो common चीज बच्चों में होती है discard meniscus, left meniscus especially. So you should not ignore the typical meniscal type of joint line pain है, बच्चा adolescent 10, 12 years and 15 years of age. Do not ignore कि नहीं meniscal नहीं होगा. So always look for do MRI and look for discard meniscus. And we have seen very bad discard meniscus which ended up in total meniscectomy. Nothing repairable. There's so much complex here, so in very young children. So there are cases come here against the constant we did not.
Why meniscus is anomaly of it's not a normal lesion, despite in children, adults, and age group. And if present with complaints, always do. So tear है despite means always present with the tear. Tears वो कितना despite का type हो है morphological type. जो presentation ने जो रतन आपने ने classification की. If present with type 2 and 3 always do. And 1 despite normally conservative according to
यस इसको और बढ़ाए ना इसी टॉपिक तो बच्चों में जो टर्म इस्तेमाल किया थर्ड यानी द मेनिस्कल थर्ड इतनी आवाज आती है उस डिस्कॉर्ड की जब वो टीयर होता है वो चलते हैं एकदम वो आप उसको मिस नहीं कर सकते वो बच्चा जब क्लिनिक में आता है टॉन डिस्कॉर्ड मेनिस्कस और उसकी एक एक्सरे भी बड़ी खास अपीयरेंस है कि आप जब एक्सरे बहुत नीट करें ना इत्तेफाक से तो आपको जॉइंट लाइन बड़ी हुई नजर आए जो इप्सिलैटरल अगर वन नी में है तो लैटरल साइड में ज्यादा होता है लैटरल साइड में जॉइंट स्पेस बड़ी हुई है वो एक्सरे में ही डायग्नोज हो जाता है अगर आपकी माइंड में आपको पता है तो आप एक्सरे को उठा लेंगे मोस्ट लाइकली दिस इट हैज अ डिस्क क्योंकि वो जॉइंट स्पेस बन गई वो मोटा होता है ना नॉर्मल से तो इट वुड काइंड ऑफ बाय सिग्निफिकेंटली आप मतलब डोंट इवन हैव टू मेजर आपको ग्रॉस से नजर आ जाएगा you have a clinical suspicion now radiological confirmation it's a discoid most likely so anything after one
मेरा सवाल ये कि when you will consider that this knee doesn't need meniscal where it is advanced osteoarthritis or degenerative knee and we should go for total knee replacement.
Basically, the type of a tear is basically what is known as a degenerative tear. These are the horizontal tear with a complex variant. And of course, this knee, when you're going to do a standing X-rays, the articular surface because of the deficient being there, the joint surface being close, and we know they're mostly tri-compartment. And these patients, when come to us with the pain in the knee joint, we know this is a older age group will have this pain. And what we always offer, well, some of the doctor advise them an MRI, and then this MRI you say there's a tear, but it's mostly not because of that meniscus tear which is causing the pain. That might be exaggeration of the osteoarthritis at that time. So you have to again start with conservative management with some rest, of course, NSAID, decrease the inflammation and see how the thing works. And after 2 weeks or so, see how the things are going. Things are getting better. So if that's me, there was the exaggeration of osteoarthritis, but this is not because of that meniscus tear. If the pain persists and there is despite like while walking they have this some locking or they have this pain, that's where we have to understand that the horizontal tear might have increase and now it is coming between the bone and that is causing the pain. So we can go and debride it. So one of the management of osteoarthritis, early grade 2, grade 3, arthroscopic debridement is also option. And now we have got elastic gels, we have got PRP, so that can be at the same time augment over there. So these are the something we have to keep in mind in osteoarthritis.
उस पर पूरी टॉक है तो उसको बाद में दोबारा एड्रेस करते हैं डॉक्टर नवीद की आई टॉक है मेनिस्कल टीयर्स इन डीजनरेटिव नीज तो उसको दोबारा आते हैं एनी अदर क्वेश्चन प्लीज सर
मेरा ख्याल है कि एक इम्पोर्टेंट बात इसमें है कि फॉर रेजिडेंट स्पेशली द मैकमुरस टेस्ट जब आप उसको स्क्विट नहीं कर सकते you have to diagnose meniscal tears or Mcmurray test. Our standing Mcmurray test is not very much diagnostic purpose, but on supine position, you have to examine the both menisci, the fingers, and you have to do proper test. To get the result, you have to at least examine 50 knees, just like they will say. Some idea about the arthroscopy, just like that, the Mcmurray test, proper Mcmurray test, you can diagnose is there an anterior heart tear or posterior heart tear or lateral or medial. That's my idea.
और एग्जाम में उन्होंने मैकमरे नहीं पूछना तो
you are talking about Mcmurray test. Why can't we use the Apple's grinding test?
वो बिल्कुल वो प्रोन में करेंगे ना
प्रोन में करेंगे
तो आप सुपाइन में भी आने चाहिए आपको एग्जामिन कैसे करना है अब बहुत सारे लड़के उधर एग्जाम हम देख अब जॉइंट लाइन क्या जॉइंट लाइन palpation is fundamental to palpation of the knee joint right should know where the joint line is. वहाँ पे meniscus पड़ा है. So then supine examination of the meniscus, prone examination of the meniscus, and standing examination. भाई तीनों आपको टच हो गए, तीनों टेस्ट आपको पता चल गए. Clinical examination आप
क्लिनिकली तो आपको पता होना चाहिए कि कौन से टेस्ट हैं.
चलिए, any other question? पार्टिसिपेंट कम सवाल करें, एक ही पार्टिसिपेंट बार-बार सवाल करें, बाकी लस्सी ज्यादा पिए.
Meniscal transplant or prosthetic meniscus after meniscal meniscectomy.
वो बिल्कुल है, हमारे यहाँ नहीं है, उसके लिए वो टिश्यू बैंक होना चाहिए. Meniscal transplant is for complex tear, and I have, believe me, every faculty must have seen that very bad tear. और मैं आमिर से यही सवाल करना चाह रहा था, वो चले गए ज़रा टाइम कम, कि हमारे पास बहुत लेट पेशेंट्स आते हैं, साल घूमते रहते हैं इधर उधर, ओपिनियन, they cannot make up their mind. Finance is also a bottom line issue, but they cannot decide. So by that time, their edges are so worn out and they have converted themselves into complex tear. Believe me, I have seen meniscus being involved by a complex tear. So I ultimately have to वहाँ जगह बनती है जो आप पूछ रहे हैं, वो टिश्यू बैंक से होता है, उसने वो रूट्स के साथ, बोन के साथ उठा लेते हैं, बैंक में रखा, और फिर आपने साइजिंग की. जब आप रिसेक्शन करके आ गए, आपने साइजिंग करवाई, इंट्रा साइजिंग की, MRI से ट्रांसप्लांट पे हम टॉक्स भी रखते हैं, जब खालिद साहब कभी-कभी पूरा डिटेल में हम करते हैं एडवांस वर्कशॉप.
आसानी वाले तो कैसे कहीं ना कहीं पूरी बेस पे ही ना वो आदमी हुआ सेकंड वाला नहीं हालत सही मैं चाहे कितना नहीं नहीं सकते
साथ भाई हाँ
साथ तो है ही.
साथ वाला
हाँ जी, आइए तो जी.
What is the role of biologics in these injuries, and what are the options we have got?
ये सब आप हमारे ख्याल करें, जरा मौसर करें, आप बहुत डिटेल.
मेनिस्कस इंजरी की बात कर रहे हैं, तो मेरे ख्याल में बहुत क्लियर एविडेंस नहीं है, वी हैवंट स्टिल स्टार्ट टू यूज इट, लेकिन different clots and PRP, there is some role. You try to, when you are doing meniscal repair with ACL, and you know very well, it's published कि उसके chances अच्छे होते हैं healing के, repair 90% success rate है, because of you are providing a more favorable environment, bleeding वगैरह होती है. तो different clot use करना, PRP use करना, they are helpful, beneficial. जो लोग PRP नहीं जाना चाह रहे हैं, at least different clot you can use, or you can drill some holes in the condyle, जिसमें जब ब्लीडिंग का डेफिनेशन टाइप की चीज होगी, ब्लीडिंग हो जाती है, तो एक बायोलॉजिस्ट देयर मे बी सो मेनी थिंग्स इन द वेस्ट, मतलब हम नहीं अभी यूज करें, देयर इज नो कन्विंसिंग एविडेंस वहां पर भी कंट्रोवर्शियल है.
Any glue for that?
So आवाज साफ नहीं है.
Is there any glue, biologic glue for that?
ग्लू एक तो फिब्रिन ग्लू है, फिब्रिन ग्लू आती है, वो हम यूज करते हैं. नी में मैंने कभी नहीं यूज की. नर्व रिपेयर, वेसल रिपेयर, इनके फिब्रिन ग्लू हमने यूज की है. बट आई यूज आफ्टर मेनिस्कल रिपेयर a PRP shot, and after ACL reconstruction with meniscal repair, definitely yes, a PRP shot. But let's take a poll from faculty.
मेरा क्वेश्चन मसूद उमर, forget about faculty.
खालिद साहब,
मेरा आवाज आ रही है?
हाँ जी बोले.
आपने वो जो ग्रेड 2 टीयर में इंजेक्शन दिया था स्टेरॉइड का, क्या आप उसमें PRP दे सकते थे instead of steroid?
PRP HA भी दे सकते हैं, बिल्कुल दे सकते हैं, इस पर रिपोर्ट्स भी हैं, लेकिन वो कोई जैसे नबी साहब ने कहा जो है ना स्टैंडर्ड प्रैक्टिस नहीं है अभी तक, एविडेंस जरूर है।
नहीं, can I ask you, okay, let me ask you in another way. क्या ये स्टैंडर्ड प्रैक्टिस है कि स्टेरॉइड का इंजेक्शन दिया जाए?
In grade 2 tier, no. This was just my practice.
That's fine. I have changed my practice and I have gone into PRP. जहाँ पे पेशेंट कुछ नहीं कर रहा है, अगर मुझे स्टेरॉइड तो खैर मैंने जिंदगी में कभी नहीं दिया, लेकिन अगर वो है तो I go for PRP injection. These days I have changed my practice altogether, and inshallah when we have a pass, I will be doing क्या होता है अपना, मैं पेपर निकालूंगा on PRP के injections पे for the knee.
ठीक है, खालिद साहब आपसे क्वेश्चन
पार्टिसिपेंट्स की इंफॉर्मेशन के लिए PRP is platelet rich plasma, और एक और बायोलॉजिक्स है जिसमें अभी इरफान साहब ने हल्की सी आवाज मार के मुझे फंसाने की कोशिश की थी, वो है स्टेम सेल। मैं इसलिए बोला था कि मेरा इसमें इंटरेस्ट है, मैं अडल्ट स्टेम सेल्स इस्तेमाल करता हूँ। दोस्त यार मेरी क्लास तो लेंगे, मगर कुछ पेशेंट्स में और कोई ऑप्शन हमारे जो हालात हैं उसमें नहीं होती। ऑप्शन एक ही है बहुत एडवांस्ड ऑस्टियोआर्थराइटिस में, और वो TKR है। अब आपको भी पता है कि हर कोई TKR अफोर्ड नहीं कर सकता। फिर एक सर्टेन ग्रुप है जिनको ये प्रॉब्लम होती है, वो 60-70 का एज ग्रुप है, वो लोग अपना असल वक्त तो गुजार चुके होते हैं। अब उनको हम अगर इतनी एग्रेसिव अप्रोच करेंगे तो शायद वो मॉबिलिटीज के साथ उनके लिए फिजिबल ना हो। तो मैं अडल्ट स्टेम सेल इस्तेमाल करता हूँ और उसकी स्टडी आर्थ्रोस्कोपी के साथ कर रहा हूँ। इस वक्त तकरीबन 157 नीज की स्टडी है जो हमने फंक्शनल स्कोरिंग के साथ की है। वो डाटा हम अपनी किसी एक उसमें कॉन्फ्रेंस में भी प्रेजेंट करेंगे, और उस डाटा के हिसाब से पेशेंट को बेनिफिट होता है। जैसे अभी शम्स ने कहा कि हमने एक्सरे को ट्रीट नहीं करना, हमने पेशेंट को ट्रीट करना है। और आमिर भी 2 रेफरेंसेस दिखाए थे उन्होंने, जिसमें फंक्शनल स्कोर मेनिसेक्टमी का भी और रिपेयर का भी बराबर आ रहा था। फर्क सिर्फ ये था कि ऑस्टियोआर्थराइटिस के चेंजेस एक्सरे के ऊपर ज्यादा इंक्रीज कर गए थे। तो अल्टीमेटली अब वही डायलेमा है कि पेशेंट को फंक्शन चाहिए या उसको अच्छा एक्सरे चाहिए। तो ये फिजिशियन की
आपकी सोच क्या है खालिद साहब?
मेरी सोच है जी कि जो मेरा पेशेंट पेन में है और वो किसी भी वजह से TKR अफोर्ड नहीं कर सकता या करा नहीं सकता, तो एज अ फिजिशियन मुझे उसे कुछ ना कुछ ऑफर करना चाहिए, और अगर उसको रिलीफ हो जाए तो वही मेरा एम होना चाहिए। इस लिहाज से मैं उन्हें स्टेम सेल ऑफर करता हूँ।
नहीं, मेरा मतलब था लाइपोसाइट का आप यूज करते हैं या फैट वाला या?
नहीं, मैं ब्लड वाला सेफेस्ट है, FDA का अप्रूव्ड है, वो इस्तेमाल हो रहा है। ये जैसे डायलिसिस की मशीन है, सेंट्रीफ्यूज करते हैं, बट वी पास द ब्लड थ्रू देयर, उससे पहले 2 दिन उन्हें एक्टिवेटर इंजेक्शन देते हैं जिससे प्रोडक्शन इंक्रीज होती है और मोनोन्यूक्लियर सेल्स जो है।
ठीक है, एनी अदर क्वेश्चन? जी
सर, एक ही नीचे अंदर लैटरल मेनिस्कस और मीडियल मेनिस्कस दोनों का टेयर है, लेकिन एक ग्रेड 2 का है और एक ग्रेड 3 का है, तो हम क्या दोनों को रिपेयर करेंगे?
टू की तो हमने बात कर ली ना कि 2 is depending on the symptoms, right? So if there is a 2 and you think it's almost a 3 when you scope it, or you probe it and you can pass the probe through and through, then it's a 3, right? And if you think it's repairable, why would you repair that? 3 का तो बात 2 की इसीलिए मैंने controversy raise की कि 2 is an undefined grade 2 injury, right? So grade 3 तो बात हो गई ना clear. If it's an indication for repairs, go for it. Yeah. मुझे टाइम मिला तो आप दोनों साइड पे रिपेयर वो कर सकते हैं. कोई contraindication
Based on the clinical condition, what are the symptoms of the patient? You are treating the patient. If the patient is having a complaint, walking, and on the right side, on the medial side, having a complaint of knee pain on the middle joint line, and no pain clinically, and no pain on history on the lateral side, you treat the medial side. And if patient having both the medial and lateral meniscus on MRI here, and having both side pain clinically and radiologically, then you treat both.
अगर आपका सवाल ये था कि दोनों साइड पे रिपेयर हो सकता है जॉइंट के तो हो सकता है, provided you have correct indication and provided Dr. Khan said the patient is symptomatic on this.
So basically, what we had the debate or what we were the discussion was grade 2 we need arthroscopy or not, right? So we were just saying, shall we arthroscopy the patient or not? Now you're inside the lesion and you can see grade 2 or grade 3 whatsoever, and at the same time grade 3, you have to repair it. So you don't want to leave it again if you're done with grade 3, so you can go again and just do arthroscopy. So if there you can see things are there, you have to repair so that to minimize the chance of increasing the size.
The grade 1, grade 2 tears are more. Grade 2 tear you can identify asymptomatically on knees of 40s and 50s. 40 और 50 साल के जितने भी खवातीन हैं, उनमें grade 2 नियर नॉर्मल है, grade 2 tear. तो symptoms क्या आपने patient को treat कर. अब if the grade 2 tear causing pain and symptoms for longer than 3 months after the failure of your conservative management, then treat. Otherwise, no need to treat grade 2 tear.
ये लाइक साहब लाइन पे आ गए.
मलिक साहब आए हुए हैं.
मलिक जावेद इकबाल साहब आप लाइन पे हैं?
जी जी. आवाज लाइन पे तो आप लोगों की आवाज क्लियर नहीं आ रही.
अब आ रही है सर?
अब आ रही है. आप जब बोलते हैं तो आवाज ठीक आ रही है, लेकिन जब पार्टिसिपेंट या फैकल्टी बोलती है उस वक्त आवाज क्लियर नहीं होती, फिर वो फेल हो जाती है, दूर हो जाती है, फिर वी कांट हियर व्हाट एग्जैक्टली.
आपका ओपिनियन क्या है इन ए ग्रेड 2 meniscal tear? What is your treatment plan for a symptomatic patient? So MRI पे grade 2 injury आई.
For grade 2 tear, for grade 2 tear जो है ना, first of all, I mean, let's define what tear is. I mean, it is just a tear which is actually in the one surface of the meniscus, right? So it's on the undersurface or the oversurface. If it is symptomatic, and if it's symptomatic is mainly just in pain, then I have to really know what exactly is the cause of this pain. I mean, obviously, if this tear is only in the white surface, then probably this is not really the cause of pain. The cause of pain must be something else. And with something else, maybe it may be just synovitis, which is the byproduct of this tear, because the environment is not known, and there are changes happening in the knee at the same time. So it is. So if the symptoms are mainly mechanical symptoms are coming from this grade 2 tear, which is more unlikely, but if it is, then obviously it needs to be treated. But if it's not, then the symptom and the pain is coming from something else, then I think we need to go and look into a bit more depth and see what exactly is causing the pain. So I mean, when the actually tear starts, it's not just the tear; there are also biochemical changing starting in the cartilage as well. You see there, so there is start of the osteoarthritis at the same time. The tear is only what you are saying. Is only the tip of the iceberg. There are other changes going on at the same time in that environment. So we must not forget to look into those changes as well. And those changes which are happening, that may be the cause of the pain, not exactly the tear. Because as we know, if it is in the mostly this grade 2 tear, they are in the white zone or the red-white zone. So, and it is a neural structure. So it shouldn't be causing pain that much if it is really undisplaced and that not that much kind of tear. But obviously, we need to look into others as well. But if it is symptomatic, then obviously yes, we need to go and have to treat it. So far, I mean, we don't have those techniques and those the instruments, the gadgets, which Dr. Amir has. So obviously, we need to go and to treat this tear by partial meniscectomy, if it needs to be.
Thank you, sir. अच्छा जी क्या करना है? Should we take a tea break for 15 minutes?
Yes.
First talk ले लें. हाँ जी, dominant majority क्या चाहती है?
Yes.
चलें थोड़ा सा break कर लें. शम्स साहब आप भी try हो गए. So next talk is on very important aspect of our whatever work we do, whether we do it surgically or whether we do preservative in the rehab management. We will even talk about exercises after meniscal injury before repair, and then obviously after repair, what are the exercises focused on meniscal injury. So Kashif is our therapist at ATU. He will in the next 15 minutes or so take us through those exercises. Over to you, Kashif.